being recorded. And then we're going to go live. Let me spotlight myself. I guess I have to get myself ready too. There we go. Okay. We're going to start the webinar. Hi, everybody. Welcome. Just going to give it a couple more seconds for folks to join. It looks like our attendee count is still climbing. Great. Well, let's get started with just a couple of logistics reminders before I turn it over for the welcome. We continue to meet virtually, so this meeting is available on your smartphone, on your tablet, on your computer, and you can always dial in on your phone. Live captioning and American Sign Language interpretation is available. To enable captioning, please select the CC or live transcript icon on your Zoom toolbar, and you should see the subtitles populate there. The recording slides and transcripts are archived and will be posted to the California Health and Human Services Community Living webpage. And we are saving time for public comment. So for those who are joining us via their computers or smartphones or tablets, you can use the Q&A function to submit a comment or question, and we'll read your questions aloud during the public comment period. You can also use that raise hand icon to join the queue. And those who are joining by phone can press *9 to join the queue, and we will unmute your line to hear from you directly. And with that, I know that Director DeMorris is actually, I think, doing a presentation as we speak and will be joining us later today. So Sarah Steenhausen has volunteered to do the welcome for us. So Sarah?
Well, thank you so much. It's wonderful to see everybody here. Thank you all for being here. But I'm really pleased that we have been joined by Darcy Delgado, our amazing Assistant Secretary at the Health and Human Services Agency, who's been a really valuable partner on all of the issues pertaining to the Master Plan for Aging. And because Susan is speaking right now at Assemblymember Nazarian's Town Hall on the Master Plan for Aging, she'll be joining us in about 20 minutes or so. And Darcy is going to make a few opening remarks on her behalf. So welcome, Darcy, and thanks for being here.
Thank you, Sarah. Can you hear me okay?
Yes.
Perfect. Okay, great. Welcome, everyone. For those who I have not met yet, my name is Darcy Delgado, an Assistant Secretary with California Health and Human Services Agency. I'm having a little bit of FOMO today, fear of missing out, because I hear that Glendale is just the place to be today for all things related to aging and the disability community. And apparently I missed the invite to New Orleans a few weeks ago. So your guys' group does a lot of really fun things, but super happy to be talking with everyone today. And really on behalf of our secretary, Dr. Mark Galley, want to thank you all for your commitment to the Disability and Aging Community Living Advisory Committee. The work that you all have done, I've only been in this position for 9 months, but to really wrap my head around all of the work with CalAIM, the direct care workforce, housing, transportation, it's just amazing to really understand and see all of the great work that DACLAC is doing in these areas, and really appreciate your groups taking the time to learn more about the proposed care court framework this afternoon. We know that there's been a lot of stakeholder engagement, and I know from the secretary, he's very interested in ensuring that we are listening to all of the stakeholders' feedback on the care court proposal. So excited to hear the proposal being presented to you all today, but more importantly, to hear the feedback. And so, when I hear Dr. Galley speak a lot about busting silos, this group is really one example of that in practice. And so just really grateful to all the experts on this committee. And I'd like to give a special shout out to Patty and Eric for your leadership. the diversity of the perspectives at this table is unlike any. And so it is just incredibly important to keep lifting up the voices that you all bring to the table. So thank you for your work in this area. So today's Wednesday, 2 more days until the governor will be releasing the May revision to his budget. Really excited about what not just Cal HHS agency will be lifting up in terms of new investments, but also look for exciting investments in some of our sister agencies, housing, labor, natural resources, transportation, and I think that our agency and the administration as a whole is looking forward to building on the historic investments that were made last year, and how can we leverage the dollars in this year's proposed budget to better continue our implementation and really improve upon that in the master plan for aging. We know we're in year 2 now, and very excited to have you folks be weighing in on the next round of the master plan for aging and the priorities that we need to be focusing on. I do think that the next 2 years are very critical in building out the systems that we need to support older Californians with disabilities, and caregivers, as we are not only focusing on year 2 of the master plan for aging, but our 10-year blueprint for California. So excitement for what's coming on Friday, but also just a lot of other great things that I want to touch on, just to make sure that everyone in the room is aware of all of the different pieces that are touching older Californians and Californians with disabilities. So this month, very excited and very proud to extend the full scope of Medi-Cal coverage to all undocumented Californians age 50 and above. It's so incredible to be part of a state that is looking to provide that support to undocumented Californians. And so just really proud of that effort. We are also right in the thick of implementing some current dollars, over almost $1 billion in direct care workforce investments, strengthening IHSS, and looking forward to how the potential dollars in the proposed budget can supplement those workforce related issues. And so again, thank you all for being here. Really excited for all of the discussions that will happen. And please, everyone, watch for an announcement from our secretary, Dr. Mark Galley. He will be holding a secretary stakeholder call once the May revise is released, and hope that you all can join, bring your questions, bring your comments, because I see our agency as valuing that active listening, and we want to hear from you, not just today, not just on Friday after the May revise is released, but throughout the year as we are working together in collaboration to lift up all of these efforts. So thank you again for having me, Sarah. I will hand it back to you.
Great. Well, thank you so much for those remarks, Darcy. It's great to have you here. And I want to turn to our wonderful co-chairs, Eric Harris and Patty Prunier, to see if you would like to make any opening remarks. Eric.
Thank you so much, Sarah. My name is Eric Harris. I'm one of the co-chairs of the DACLAC committee, and I'm also the Director of Public Policy at Disability Rights California, use pronouns he, him. And I am really looking forward to this conversation. And I think that we have a full agenda with a lot of different presentations for everyone on a number of different topics. And we are really looking forward to the engagement piece. I know that that has been, as you all know, a priority for the co-chairs. It's been a priority for Susan, and we really want to make sure that that's always a major portion of each of these meetings, so that we listen and engage with you all, and that you all are able to give your thoughts, critiques, ideas, so that we can have those ideas and move forward to make this DACLAC committee the best it can possibly be. So with that, I'll go ahead and pass it on to Patty.
Thanks so much, Eric. For those of you who don't know me, I am Patty Prunier, Senior Housing Attorney at Justice and Aging. I am delighted to be sharing this co-chair with Eric, my partner. And I wanted to thank Darcy for her warm appreciation of DACLAC. And I think she's right that we have a unique composition and mandate to really bring the different pieces together to advance community living. And you'll see that in the work that we've done and in the agenda for today, which is going to really focus on the work that can be done in the subsequent year of the master plan for aging and assessment of where we are and how we can move those goals forward. I think we'll also do a deeper look at two key areas that are sort of the heart and soul of advancing community living. And that's community supports to advance independent living for older adults and people with disabilities. And that will be the Cal AIM presentation. And then we've talked a lot about housing, and the both the housing and transportation subcommittees will give us important updates on the work they've been doing and the priorities that they've established. And then, as Eric mentioned, it's the engagement part is so important, and we will have public comment both following those presentations, and we'll have an opportunity to talk about the care courts proposal and hear from our community about that as well. So it's a rich agenda. It's a very packed agenda, and it begins with our executive director at Justice and Aging, Kevin Prindeville, kicking us off with some report on the MPA Impact Committee. Thank you.
Thank you so much. Appreciate that so much, Patty. And we're so happy that we get to hear from Kevin now. And I just want to say before we turn it over to Kevin, what an amazing partner he has been on behalf of leading not only Justice and Aging, who's been such a critical partner, but really engaging and working with all stakeholders in the development of the master plan and now into the implementation of it. And Patty and Eric, I love what you said about the importance of engagement and the model that you both are setting by leading this committee and helping co-chair it, helping set the agendas, helping ensure that our advisory committee, or sorry, our subcommittees are so engaged and bringing forward such great ideas. So with that, Maria, are we doing committee member introductions? I don't think we're reading through everybody. Am I correct?
No, I don't think we will. I think there's a lot of
Okay.
folks, so we want to use our time wisely
Great.
today, but we'll scroll through them really quick and just encourage members to say hello in the chat as a way to introduce yourself. I think Patty covered the agenda, so we could probably skip that slide too and turn right over to Kevin if you're ready.
Great. Thank you, Kevin, for being here and talking to us about your work on the Impact Committee and in preparation for our Day of Action in September.
Yeah, thank you, Sarah, and thank you to CDA for continued engagement on all these issues, and thanks to Patty and Eric and the whole group here. It's wonderful to see you all again. I really appreciate the work that you're all doing as part of DACLAC. It's the beefiest of all the committees, I think, in terms of really tackling a lot of the key issues that are so important to all of us and to older adults and people with disabilities across the state. I'm here today wearing my hat as a member of the Impact Committee. The Impact Stakeholder Committee is one of the Master Plan for Aging committees. We're the committee responsible for looking at everything together and providing advice on implementation and holding CDA and the whole of government accountable on implementing the master plan. In our last meeting, which was last month, we released our report. I apologize, I've got a neighbor running some loud equipment, so hopefully it's not too distracting for you all. It is for me. But last month, we released our first MPA reports with feedback on year one of implementation. From what I understand, the report was included in the meeting materials. One of the things we highlighted in that report was a good thing that's happened in the first year is the appointment of key leadership in aging and disability at the state level. You know, people like Susan and Kim and Sarah and Claire and Darcy, others on this call that have really stepped up to provide leadership in key agencies. And then also we think it's very positive that these numerous stakeholder committees like DACLAC and the Impact Committee and others have been created and are up and running and figuring out their role and taking on important work. All these committees are really important to the success of meeting all of the goals of the MPA. Given that there are so many committees, however, and they're all taking on really important scopes of work, the Impact Committee did observe that there could be increased alignment and coordination across the committees. Opportunities to really strengthen understanding of what each committee is doing and building partnerships between, so that we're all keeping going in the same direction. With that in mind, we also think that the committees can play a critical role in helping define these next years of the MPA. So the initial plan outlined a lot of initiatives that were for the first 2 years. So the Impact Committee has been talking to CDA about how we plan for the years beyond and how we leverage all of the committees like DACLAC and others to do that planning for beyond. So with all this in mind, the Impact Committee has been talking to CDA about how to engage and get input from all of the committees and councils that have been created. And so what we have in mind is that we would like each of the committees to have a process where you can put together and provide feedback on what your top priorities and recommendations would be for years 3 and 4 and beyond of the master plan for aging. So sort of taking a moment to reflect on what's gotten done so far and then think about what should be done different or should be done deeper as we move ahead. The Impact Committee's given some advice to CDA about building like a standard template that each committee can use to come up with those ideas. We'd like each of the committees to develop priorities or a platform or whatever makes sense for your committee over the next few months. And then the big news is that would all be shared as part of a big convening that's being planned for September 20th. I think there's a slide up about this. The California for All Ages and Abilities Day of Action. This is going to be in-person events, health willing, in Sacramento. It'll be a chance for everybody who cares about the master plan for aging to come together and do that planning together for what the next several years of the plan look like. And as part of that day, there'd be opportunities for each committee to present on what you think the priorities should be moving forward. This idea is kind of modeled on a White House Conference on Aging, a day for us to come together and for the whole state to think deeply about aging, issues of aging and issues for the disability community. I want to say that the Impact Committee developed a report, like a written report. In our report, we identified 3 big recommendations for moving forward. The first was to focus on some big things. So the first 2 years of the MPA, CDA, and the whole of government have been working on over 100 and whatever initiatives. It's been a lot. It's been a lot to track. Some of them are big, some of them are small. We'd like to see some focus moving forward on trying to tackle a couple of big things together. And the things the Impact Committee identified as the big things to focus on would be home and community-based services, and how do we really build a system for providing care to people at home and in the community. And the other issue was elder homelessness. How do we solve the problem of homelessness for older adults? That was one of our recommendations. The next recommendation was to go deeper on equity. And then the third recommendation was to keep the governor really involved, to really use the governor as a voice for highlighting the importance of aging and disability across the state. So those were our 3 recommendations. And we're a smaller committee. We were able to write a report. That might not be practical for every committee. So, the Impact Committee is certainly open to DACLAC finding its way to get ideas on the table for everyone to consider. So for you all, that might be looking at the template that gets developed and each of you doing some thinking on your own about what you think the priorities would be. And then maybe at your next meeting, you have a conversation. And then we ask the co-chairs to report out to the Impact Committee of what you heard as some of the big themes and recommendations. And then we'd work with you to kind of turn that into a presentation at the September 20th event. So, I don't want to sound like I'm here giving you all too big of an assignment to tackle. But what I am here is to invite your feedback on these questions about where we should all be going next. And we want that to be something that feels practical to you all in terms of how we get that done. But the what we're looking for, I think, is the main thing, is we really want you all to be bringing your expertise to the table here so that we can continue to push each other in the state to say what next will help us meet the greatest needs and take advantage of the best opportunities in front of us. I think I covered everything I was hoping to. So happy to take some questions about this, or if we're behind on the agenda, also happy to take questions offline.
Thank you, Kevin. Looks like we do have a question from Greg.
Hi, thank you. And thank you, Kevin, for your report. Obviously, I'm extremely interested in goal number 1, especially related to IHSS. So if there's any way you need any help on any of the committees, please feel free to reach out to me, and thank you for your work.
Thanks, Greg, and good to see you.
Great. We'll take one more question from Michelle, and then I would just encourage committee members to use the chat to connect with Kevin, and we'll move on to our next agenda item. And pretty packed agenda. So Michelle, go ahead and jump in.
Yeah, when you talk about equity, I'm glad that's something that is on your agenda to do. But I think bringing all our services and things that we need to be able to live in the community is very important, and not to leave out any one area of importance. I think the lack of transportation and housing and other things is so important, and we just need to remember that it's all part of what services we need to have, and have a huge impact on giving those services in a way that is accessible to everybody who needs them. Thank you.
Great. Well, thank you so much. And I know that it looks like Susan may have joined us, so I'm going to hand it over to her and see if she'd like to introduce our next presenter.
Definitely. Thanks, Maria. And Kevin, thank you so much for joining us. Thank you for the work of the Impact Committee and for taking time to be here today and committing to help DACLAC and other groups move from here to September 20th so we can make the best use of the input and feedback that we get. Thank you. Thanks so much for being here. Appreciate it. And now it's my pleasure to open up the conversation on CalAIM community supports. And we're fortunate today that we are joined by Brianna Ensslin-Janowski. I hope I said that correctly. She's with ATI Advisory and has been doing extensive work, research work, and recently produced a report that I think is of great value. And we're going to be hearing from her about the work with the Department of Healthcare Services and our CalAIM initiative here in the state of California, and opening it up for questions and comments after she presents. Welcome. Thank you so much for joining us, Brianna.
Thank you, Susan. Thanks for having me, everyone. And it's nice to meet those of you that I haven't before. Very quickly, Bree Janowski, I am a director at ATI Advisory, which is a small research and policy firm focused on complex care and specifically older adults and individuals with disabilities for a lot of our work. So really happy to have a chance to chat with you all. We've been working to look at MCPs, so managed care plans, thinking and processes, and the early launch, I'd say pre-implementation and launch of community supports, specifically looking at 6 community supports that are most focused on supporting independent living. So we can go to the next slide. Very quickly, I'll cover our work and what we did. Then we'll take some time to look at those 6 community supports, early adoption from the plans, and some lessons that we've learned and what we heard from plans around why you see the things that you're seeing in terms of adoption rates of different services by different managed care plans. And then really spend time talking about what's next and how we move forward from here. So yeah, we can go to the next slide and talk about our work here. So we were supported by the California Healthcare Foundation, who was really interested in saying, this is a great opportunity. Community supports are presenting this tremendous opportunity for California that we really haven't seen nationally in a similar magnitude. So looking at the experiences of plans and understanding what's inhibiting their uptake, what can we be doing to broaden the uptake and do so equitably. So to understand what was going on, we interviewed national plans that have experience with in lieu of services, which is what community supports are called nationally. We talked with plans in California about their experience over the last year or so, thinking through these services. And we also did really extensive research into the literature out there on these services. What do we know about how effective they are and what the benefits are for beneficiaries, for plans, for states. And we looked at regulations, we looked at plan experiences, there's a lot in there. And ultimately produced a few different resources. So we have a slide illustrating each of these. So all of these resources are available on California Healthcare Foundation's website. So I encourage you to go dig in there. There's a lot in here. So there is a full report which talks about each of these 6 supports that we're going to highlight and are most interesting for the conversation today around independent living. So we have 2-page profiles of each of those community supports, illustrating what they are, early experiences of managed care plans, what they were thinking about in terms of offering them, data available on how effective they are, and then recommendations for both plans and the state to think through to promote greater uptake. So that's resource number 1. We go to the next page. The second resource that we put together is pretty interesting if you're interested in data and understanding how effective these different services are. So what are the benefits of respite services? What do we know about the impact of meals? And you can go through and you can filter and understand, are there positive outcomes associated? Are there outcomes positive, negative, neutral for caregivers, for utilization, et cetera? So if you're into data, you can really dig in here for quite a while. So encourage you to take a look there. And then the next slide features the third and upcoming resource coming out of our project, which is a webinar next week with Kate Myers from the California Healthcare Foundation and Carrie Graham from the Center for Healthcare Strategies. And we're really going to be talking about the intersection of the long-term care institutional carve-in and community supports under CalAIM and what that all means for the state moving forward. So if you're interested, encourage you, again, this is on the CHCF website, and that webinar is, I think it's next Thursday. So we can then go to the next slide, and now we're going to dive into community support and these services that we're talking about. And the next slide, we start with a quick conversation on how this all fits in with CalAIM. And I think everyone here is familiar. CalAIM is the Department of Healthcare Services initiative to transform the Medicaid delivery system. A lot of this builds on great work that the state has been working on for many years now. The early implementation of community supports and enhanced care management in January of this year, I think we can really think of as laying the foundation for a lot of these subsequent initiatives that are going to roll out for CalAIM, specifically focused on supporting individuals to live in the community and do so well. So community supports we'll talk about a lot more. Enhanced care management runs alongside of that and can be supportive of making sure individuals get the community supports that they might need. And then we'll see that really be foundational for the eventual rollout of the institutional long-term care carve-in, expanding MLTSS into new regions across the state, and ultimately thinking about aligning all of that with Medicare, which is what you see along the bottom in terms of alignment with DSNP, so dual eligible special needs plans. All of this is meant to create one system, one unified system to provide whole person care and really individualized care for individuals and their unique needs. Okay, so what are community supports? What are Medicaid in lieu of services? If you're familiar, if you're not familiar with Medicaid managed care, those plans have the ability to deliver services within their Medicaid state plan, whatever is in their contract. This is an opportunity to give greater flexibility, recognizing that members are different, each individual is different and their needs are different. So this provides an opportunity for plans to voluntarily say, we want to offer this array of other services that are cost-effective, medically appropriate, sometimes non-medical services that might be in lieu of a different service. So plans have the opportunity to decide, I want to offer this, I don't, I see a value in this, I can operationalize it well for my members. And then if a plan does offer it, members have the ability to say, no, that's not for me, or yes, it is, that's great, that's just what I need, thank you. So both sides, all sides, they have the ability to accept or offer it or not. There's also the ability for plans to add new services every 6 months, and they can take away a service on an annual basis. So you'll see when we talk about the initial rollout in January, there is an expected increase in services in July, and then subsequently every 6 months, plans are offering more and more services. And then just kind of a little bit here, the last two, the state needs to pre-approve, or the state has pre-approved 14 services in California for plans to offer. And then if a plan wants to offer a different service, if they see a need and an opportunity, they can go through a process to obtain approval for other in lieu of services. And all of this, a lot of this really these services build on existing infrastructure and capacity that was developed through initiatives like Whole Person Care, Health Homes, CalMedi Connect. So that is some of what we've found is that plans have really built off of that infrastructure from those existing programs. Okay, we can go to the next slide. Thank you. So here you have a snapshot of the 14 pre-approved community supports in California, and you'll notice a lot of them are focused on kind of a more behavioral health lens. The 6 at the bottom are those that we've assessed to be the most supportive of independent living for individuals with disabilities and older adults. And what you'll notice, unfortunately, is that there was a slower uptake of some of these services overall. So dehabilitation is the one outside of the orange box that has the lowest initial uptake by plans. And what we heard with that is that there was just, quite frankly, a lot of confusion about who those providers might be, whatnot. Otherwise, for the focus of the work that we looked at, there is an initial lower uptake, but we are seeing in June and subsequent kind of 6-month iterations from what we've seen with plans, they intend to roll these out over time. I think it was a lot of capacity. We'll talk about why that is. But a slower start, but exciting to see, and meals being the number one for the 6 services we're focused on in terms of what plans have decided to offer from the get-go. And we learned a lot of that was plans had existing relationships with meal providers, so they knew they could equitably offer that service in their service area. So if you're interested in learning more, there are updated full matrices of which plans, which counties at the link at the bottom of this slide. So welcome you to dig into that further. We can go to the next slide. And here we talk about some of the considerations. So this was an opportunity for plans to think through how do I work with the state? What do I want to launch? What do I see value in for my membership? What do I have experience with and feel confident I can implement in an effective and equitable way? So I'm not going to go through each one of these. We talk about them pretty extensively in the report, but the key takeaway to understand in terms of what we learned about plans, experiences, or decision-making processes was that for the most part, they saw these as all beneficial services. It was really a matter of how do we operationalize these services and how do we operationalize them equitably within our service areas? How do we find those provider partners and support those provider partners to engage with us? And that was the primary limiting factor in plans offering these services from the get-go. So we'll talk more about that as we keep going. Here, I want to spend a couple slides talking through scenarios of what does this mean and what are these services look like in action. So we can go to the next slide, please. And 2 high-level scenarios of how community supports or these community supports could wrap around to support an individual. So this individual, this hypothetical individual could be a member who's been in a nursing facility, but they've only been in a nursing facility, let's say, for 35 days. So they are not eligible yet for the California Community Transitions Program, which is the existing Money Follows the Person program that helps people if they're able to be transitioned out of a nursing facility home. So it's determined they're not eligible for that service, but they are eligible. They have the means to transition home and the ability. So they are connected with the Community Transition Services nursing facility to home community support that helps them with utilities for the first few months when they're home, helps them reintegrate back into their home setting. They're transitioning home to live with their spouse, who will be their primary caregiver. So they set up respite services proactively for the family member, home modifications to support a new wheelchair, new equipment, and meals to support successful living at home and management of chronic condition. So this is just one example of a myriad of ways of how these different services can be pieced together to support people to live in the home. So that's example one. We can go to the next slide. Another example here, you have an individual, they're living at home, they're at risk for institutionalization. They may be eligible for in-home support services, but they haven't been approved yet for those services. So during that waiting period, while they're waiting for IHSS, their plan can connect them to community support so they can then get the personal care services through the community supports. They can also get the home mods and meals they need to better wrap around them and support them to live well in the community. So there's a lot of different ways those could be pieced together. Those are just two examples to try to illustrate how this fits into the larger healthcare system, because that is something we've heard consistently in terms of how does this piece together with all of the other really similar services that are out there, and there are nuances, and it is something to work through for sure. So moving forward, let's go to the next slide, please. A lot of what we heard was capacity building for plans and for providers. So before I dive into our recommendations, really exciting opportunity if you're not familiar with the opportunity for providing access and transforming health, the PATH dollars. If these dollars go through, there's a great opportunity here to basically the 4 buckets below to support community support and I think equitable distribution of availability of these supports. And what PATH is recommending or would be doing is really mirrors our recommendations and what we heard from plans about what's needed. So this is wonderful, really exciting. I think the risk here and what to keep in mind is how do we make sure that these dollars go to those community providers who might not know about PATH, might be in that rural area, who could be providing services in an area where community supports aren't available. How do we support those providers to access these dollars? So something to keep in mind, something to keep track of. There's technical assistance potentially through PATH, collaboration building for ECM and community supports, plans, providers, and infrastructure support as well, potentially through these PATH dollars. So this will, again, largely mirror what you'll see with PATH. We put these together based off our conversations with plans, and what we heard was that continued detailed guidance from the state is welcome and appreciated and would really help efficient uptake of these offerings. We actually went into the project thinking that plans would want the flexibility and less guidance, and we heard the exact opposite, that plans really wanted very detailed guidance. It really helped them understand and implement these services. Technical assistance for providers, I think also supporting plans to share information on an ongoing basis, be very helpful. Sharing information in terms of what those services are that plans are offering outside of the 14 pre-approved community supports could be very interesting and help expand access. The third bullet here is a little off from this capacity building conversation or kind of theme in terms of what's needed, what's next. But there is a nuance here there's an opportunity to uncouple some of these services from a pre-approved standpoint that could help expand access. And the example here is that personal emergency response system is coupled within or is within the home modification service. Some plans couldn't find a provider to deliver home modifications that they felt confident in, but they knew they could deliver personal emergency response. So they wanted to do that separately. So that's just a small, more technical recommendation. And then our final slide here, talking about plan recommendations for consideration. And a lot of this, again, we've heard through the last couple of slides, is having the state and plans work together to share best practices. I think really importantly, to the extent plans can share information on their community supports providers and making sure that other plans in those areas can identify those providers and potentially offer services through them as well, could help. Sharing gaps in services and collaborating with other plans, again, to solve shared issues, engaging with community supports providers and helping them access PATH dollars is key. And then working with providers here to integrate community supports into the standard care planning process. And I think, Michelle, what you were saying before I hopped in is important here. This is it. So how do we make these services fit into the community, into the healthcare delivery system in a meaningful and seamless way where all beneficiaries have access to them and they are assessed and they have the opportunity to accept or decline these in terms of if they'll benefit them or not. So thinking through not just engaging community supports providers, but also primary care physicians, others that touch beneficiaries and could connect them to these services. So I just spoke a lot. That was it. And happy now, Sarah, to take questions or.
Thank you so much, Bree. What an amazing overview. And I encourage everyone to explore the resources on the website link that we put up. It's a phenomenal report, at least coming from the perspective of trying to understand how community supports can be utilized to impact the ability of older adults and people with disabilities to remain at home and in the community, and where some of the challenges and barriers might be that can be addressed. So this is a perfect segue, I think, from the earlier conversation we had with JC Cooper, who provided the broad overview of CalAIM, and we did start to kind of get into this issue of the CalAIM community supports, enhanced care management. And I think it's a lot, there's a lot of important elements for this committee to think about in terms of the consumer perspective, how we can assure that those people who need these services can benefit from these services, how we can ensure that the community-based organizations that are providing many of these community supports have the opportunity to participate, how we can ensure these community-based organizations know how to access and utilize and partner with the PATH funding that Bree just raised, and also understanding how we can build up our capacity to work with the managed care plans and make those connections across the system. So thank you all for your great comments in the chat. And I know several of you have such important perspectives to offer. And I do see a couple of hands raised. And I'm also going to call on a few of you if I don't hear from some people, because I think there's a lot we can hear from you. So with that, Sherry Farina, please take it away. And we welcome your feedback. Thank you.
Hi. Thank you, Sarah. I really appreciate you mentioning that the CBOs know how to participate in that. My question has to do more with access. How will the Department of Healthcare Services approve those providers in homes, for example? Are they actually fully accessible? And I don't mean communication with a whiteboard.
Okay.
We've had many times where deaf people are just laying neglected and they have no meaningful communication. And, you know, they're too ill to write on a whiteboard. So it's really a deplorable situation for deaf access in nursing homes. We need some kind of control over how they approve that, how people get certified for that. Show proof that it will truly be accessible.
Thank you so much, Sherry, for your important feedback. And I think that this touches on the issue of language access in all services. I know that we have some of our partners from the Department of Healthcare Services on the line if they wish to comment, but you know, I would turn it to you too, Bree, just to see if you had within your research that you conducted any comments or discussion on this issue of access and not just language access, but also cultural competency and how we can ensure that our providers reflect the needs of the population.
Yes.
I'm happy to jump in. Yes, so it's a very important issue. We unfortunately didn't get to go too in depth on this topic. We talked a lot about rural access and just the initial contracting process, but I think it's critically important. And from what I understand about plans working with community providers, the biggest concern that we heard was that they were vetting community providers very closely for quality. And in some cases, they weren't contracting and they weren't able to offer those services because they couldn't find providers that they felt could deliver the services that they wanted. And I see that as a piece of that. But I think there's probably more going on that we don't have insight into.
Thank you so much for that, Bree. I appreciate that insight. And again, we're happy to hear from anybody in our department partners that if they wish to weigh in as well. So now I see Sherry Burns, you have your hands raised, and I think it would be very good to hear from you now because you are a provider of the California Community Transitions Program, and you also have explored building partnerships with your local Medi-Cal managed care health plan. So appreciate your being here and your providing any comments or questions.
Yeah, thank you, Sarah, and thank you, Brianna, for the excellent overview. I certainly encourage everyone to read the full report because there's so much wonderful information in there. Very, very helpful statistics. I guess my first question, I might come back with another one if we have time. As a provider and knowing that I think a lot of people were very excited about CalAIM, the expansion and going in this direction, especially since there are so few California community transition providers in many areas of the state. And it's extremely difficult for many folks with disabilities and chronic health conditions that are not Medi-Cal to get out of the nursing home and have all of the resources and knowledge and everything that they need to put together on their own, especially if they don't have family members closely affiliated with them. So they really, really rely on those of us as CCT providers to provide those services. But one of the things that you mentioned was the timing of some of these essential services. And even though we know that the transition services historically since CCT started, or MFP, is highly successful. It's valued by those folks that have transitioned into the community. It's also cost effective, all of those wonderful things, the data that you provided. But many of the counties have not implemented it and don't intend to implement it until 2023. So that makes it a little difficult for folks that are kind of waiting. The other, I guess, piece of that gap, eligibility, is that Department of Healthcare Services has a backlog of folks with regards to approving the TARs and working with the CCT community in order to do those transitions on a timely basis. And the criteria for CalAIM says that if a person is eligible for CCT, they cannot enroll in the community support program for transition services. So there's people that are kind of right now in limbo because they theoretically could be eligible for CCT, but there's a backlog, or they don't have a CCT provider in their area to help them, and they cannot participate through CalAIM yet because either the eligibility criteria doesn't allow them, or the county is not providing those services yet. So I'm wondering if you have any thoughts about that, if that's something you came across in some of your research and discussions with some of the providers, and how we might mitigate that.
Great question. Yeah, so we did not speak with any providers during this project. We spoke to plans, and really what we heard, not quite getting to your question, but the closest conversations that we heard or that we had with plans around this was the fact that if CCT was available, that they almost didn't see the initial need for a nursing facility transition benefit, community support benefit, because it is so well proven and successful. And in terms of priorities for plans as they were working through their internal capacity and provider capacity, I think that was acknowledgement of where CCT is available and successful. Might have slowed uptake in some areas, but beyond that, we didn't get into too much more.
Okay, because I know in my county here in Santa Clara County is that the two plans that we have always been, saying for the last several years that probably at least 20% of their patients would be eligible for transition services. So that's a fairly significant number of people. We're just really excited about the potential of CalAIM community sports and the enhanced care management and being able to move more people into the community. Thank you again for your report.
Great. Thank you, Sherry, for highlighting those important questions and issues. So Nina, we look forward to hearing from you.
Good afternoon, everybody. So I guess every time I look at CalAIM, there's something that dawns on me that didn't dawn on me the last time. So these 14 supports are not required, they're optional, correct? And there will ever be a day where they would all be required, or no? We don't know.
I welcome anyone from DHCS, but I can jump in. So if they are an in lieu of service, which is a federal regulation or guidance classification, if they are still in lieu of service, no, because by nature, it is an opportunity for plans to decide it would be in lieu of a different service. There's an opportunity for these services to be provided in other ways through other mechanisms, but as in lieu of service, no.
Okay, so then my follow-on question to that, and just something to think about going forward, is thinking of folks that I hear from, the members I get calls from who maybe are disabled or medi-medi. They're not immediately at risk of nursing home placement. However, they need help. This is a great bucket of services, but literally they may need the bank of issues that I hear are incredible, and the lack of availability for additional services to keep someone living safely in their home. It could be mold mitigation, it could be legal services, financial planning, and so forth. None of that is here now, but how would we get to a point, say, where they're dealing with their provider and the provider can provide them some kind of link to a pro bono or very low cost service that could assist them with these additional elements they need to remain in the community? And we may not have any answers today, but I'll keep kind of flagging that.
These are really important points to raise, and I think I'm glad this is being recorded because I think that's a great record. This is a perfect place for this committee to be weighing in. I think this voice is so important as CalAIM move forward. So Nina, thank you for those comments, and if anybody has any response to that, let us know. But I want to be sure to turn to Marty Emoto, who always has important considerations to raise on behalf of people with disabilities, and particularly our developmentally disabled population partners. Marty.
Thank Thank you, Sarah, and thanks, Bree, for the presentation. It was very informative. And obviously, it raises a lot of questions. I'm a Marty Yamamoto, California Disability Community Action Network. But I'm also a family member. My older sister had developmental disabilities, was a Medi when she was alive, and then I'm currently extended family unpaid caregiver to a 29-year-old with Down syndrome. He lives with me. I've known him since he was 7. He's also a Medi. And as Michelle, you said earlier before the meeting, or I think during the meeting, you know, how difficult it is to navigate through both systems. It was true when my sister was alive, and it's true now. And there have been improvements. And so that leads to my question, though. And I appreciate, Sherry, you mentioning the issue of access in terms of for people who are deaf. We, as a committee, have to drill that down every time we talk about change. And Sherry, I'm looking right at you. Thank you for raising that issue. And we got to together raise it on the issue of equity and access. And Kevin mentioned it too in terms of the implementation of the master plan. Because if we don't practice it, if that's not something on our minds and everything we do, then we can't expect others to do it. And because we know better, and we need to practice it. And the problem, I think, that's confronting us with these changes, which I really applaud and have been involved, you know, for the last couple of years in this, is how do we reach down to the people who actually can need this? And I'm looking at Sylvia, Yi, and Gabriel and others. How do we reach the people they serve, or my family, so they understand what is happening and how can they benefit from this? And it's not reaching them yet. And I think we all have to work together on how to make that happen, so that people in their homes, or, you know, or in the community organizations that serve the people who need services or need help, they can translate exactly what is happening in Cal-Aim. Because I think most of us can make the case that most people don't know what Cal-Aim is doing, and it is providing good benefits for people who can actually help, you know, be helpful at a time when there may not be another service available. So somehow we're going to have to identify and working together about what's the training and engagement that we need to do to reach people so they understand what's available. And that's some of this is work, you know, we talked about in our action steps, and looking at Patty in terms of the housing subcommittee about engagement as actionable steps. So I'll address that more later. So thank you, Bree. And I don't know if there's an answer to the question of how do we reach the people that actually this is meant to, you know, to be a help to. And again, thank you for your presentation.
Thank you for the comment. It's very important. What we heard, we talked with a number of plans about, and this was, mind you, we started our conversations with plans in late December. They launched the community supports in January 1st. So we had some conversations in January, but I would say it's pre-implementation is what we looked at. We'd be very interested to look at implementation and understand the rollout, because the conversations that we had in early January, a few weeks into offering community supports, we were hearing from plans, well, we set up this infrastructure to let beneficiaries know and to let care managers know, and folks help them navigate accessing community supports. And there was so much confusion. There was a lot of confusion around, oh, we're offering meals, and getting calls to say, oh, well, I want meals. But it's different, right? And understanding that the right information is getting to the right people is something that I know plans are working through. So I think you all are a great group to help continue that conversation and share lessons.
Yep. Couldn't agree more. I think this is such an important conversation. And I also think it comes to ensuring that we can, leverage things like the PATH funding and get our CBOs at the local level to also be helping raise awareness about the services available and become partners in it. So really important consideration. So Kathy Kelly, I see your hand raised. Would love to hear from you, especially given we heard a lot about the relatively lower uptake of the respite care community support, and would love any input or feedback you have or questions on those issues.
Thank you. It was a great report. I wasn't necessarily surprised about the low uptake of respite. I think it's a relatively new concept in this world, and also it requires that there's some identification of the caregiver involved, which is usually a family member or friend, in many of these situations, to identify and perhaps assess their needs for respite type services. I'm going to just say a few words from the perspective of the caregiver resource centers, which have been providing respite to unpaid family caregivers for over 3 decades. And in conjunction with looking at the values and preferences of the family and the individual receiving these kinds of services, have a broader range of choices and options, with in-home being consumer directed or by agency, daycare, and facilities. And each have their place, and each have their, the options might actually turn out to be the best option given any given situation. So we're not wedded to one option or another. It's really working with the family to make that choice. Though the interesting issue that was pointed out among some of the research in the report was that respite was far more effective if it was wrapped around other kinds of services, and they are through a common assessment, with our clients and the other services, the education and training, which was mentioned specifically, but also all of the emotional support issues, support groups, and counseling, and legal financial planning and so on are all wrapped in. So respite is part of the mix of that for the clients. The client need, or the type of care that the family is providing, is very similar to the kinds of observations of the individuals within these programs, which is of course higher need clients. Our care recipients are 90% high, indicate high 90% high care needs by number of hours provided each week, and ADLs and IDLs and medical tasks that are provided, with the requisite that our families are unpaid family caregivers, and 70% do not have any paid support, and 40% have unmet needs by family and friends to provide support as well. But regardless of last year, when we were dealing with COVID and all sorts of other shortages in workforce and community-based services being closed and so on, the CRC system provided a respite to 3,259 caregivers with over 40,000 hours of respite care. I would have to say this is mostly through the consumer directed option, because that was pretty much what was available. The other options I mentioned earlier, were not present. So what struck me about this is looking at the uptake of respite, there's a number of things. First is the choice and options within respite need to meet the values and preferences and the current situation for the need for respite, obviously. In some rural areas and in diverse communities where language is a particular issue, sometimes that's the most likely option that's available. This is particularly true in rural communities for in-home care options. That respite really should be wrapped around a variety of other supportive services, with some kind of common assessment that is provided. And there needs to be assistance also with the accessing respite. It's, a lot of the work that's done in providing respite to families is actually helping them either locate and arrange for and train the family member about employing temporary help in the home, or finding the daycare programs or the facilities and talking through what might be the best options, but also helping them access those options as well. So there's a variety of things that could be put into play to improve the accessibility and also the uptake of respite within the CalAIM programs. And so we'd be more than happy to talk about, our experience, our deep experience in this area, with the department or with other health plans to, try to pave the way for providing this kind of needed option to individuals that are already providing direct assistance to the person in the home. Thank you.
Thank you, Katie. That's wonderful. And love the idea of conversation plans on it and thinking through ways to outreach. So I know we're going to hear from Lydia and Michelle, and then we're going to turn to our housing subcommittee for their update, which Marty will lead on. So Lydia, take it away.
Okay, I know in the interest of time, I have so many thoughts that have emerged just from listening to all of you, as well as reading the report, which was very interesting. We formed quite a while ago a committee that is now meeting monthly with MCPs and the CBAS provider community. So that has been very helpful in exchanging ideas and communication. So some of what I'm commenting on or have questions about that I'll quickly share are informed by that, plus our weekly couple-hour meetings with the provider community and their experience to get their experiences, feedback, guidance during this pandemic time, especially. So first of all, the best practices sharing, Bree, I thought very good, very important. I think all of us would welcome that, and the managed care plans certainly would as well. I've been wondering about data gathering and how we, as those of us who are monitoring this and care about how successful CalAIM is, and particularly these services that are new, how data gathering and reporting will happen. And the reason I bring that up right now is it was very interesting to hear one of the managed care plans say that for community services, they'll be delegating that to their medical groups. So then the question came up, well, that's great. Those are the people who do see the members all the time and understand their conditions. I don't know if they understand fully their social determinants of care kind of issues. How then is that information going to get transmitted to the managed care plan? And who's sort of coordinating all of that? Because there's always concern when we have these conversations with managed care about duplication of services. And I think that's top of mind for, retrospective audits and so on. So that's, and then I noticed in the report, and then looking at the DHCS guidance around respite, which Kathy gave us a wonderful summary about some of the barriers and needs, that there's a conflict between what DHCS has in their guidance as to who's a qualified provider and then what Bree articulated in her report. So I think there's still, to me, that illustrates a lot of confusion out there about what is and isn't available and by whom. And then also I just worry about I think somebody raised earlier, the providers who are not currently contracted with managed care. Believe me, we've been through it. The contracts that you get are lawyerly. They're designed for medical groups and other medical providers, and they do not speak at all to community-based providers out there. So if there's any way to have some flexibility on that process, and if there's ways to connect and get experienced providers in the mix here without having to go through that huge contracting process and credentialing and all of that, boy, that would just open up the world to people who need these services. And then, I'm always worried about who's coordinating all of this. And so I just think we need a lot more conversations about CalAIM and this committee and in other venues so that we do roll this out in a way that is going to work for people and meet them exactly where they are, and using the existing providers who they already trust, know, and who know them really well as the first line of support. So those are just my quick thoughts and comments, and thanks again for hosting this.
Yeah, I think those are great ideas, Lydia. And I just had an idea. I'm just throwing it out there. It's all up to you guys, but there's nothing that would prevent us from establishing a little subgroup on CalAIM. that of this committee to really focus on it and to hone in on these issues and to establish the ongoing dialogue with DHCS and the plan. So we can talk more about that. I'm sensitive to time right now, but I think that Michelle, it's so important for us to hear from you now. You are experiencing these issues. You are such an important voice as an advocate, but as a consumer who's a dual eligible Medicare, Medi-Cal, and has witnessed what it's like to navigate the system, and would love any perspective you have on the promise and opportunity of community supports.
Thank you, Sarah. It's so hard to navigate some of these services, and I think as consumers of these services, we don't always know what services are available. I think the biggest thing is there's all these new programs and new services that are out there, and the outreach, even within the plans and other things, is just not there to get to the consumer level sometimes. And I think, and that's where all this and all the services need to coordinate together to make sure that we as consumers not only know what's available for us, but have an avenue of access for those services so that we can access those services to benefit us in the best way. So many times when I was accessing my services, I was straight Medi-Cal for more than 20 years. And then I got Medi-Medi, and the services divide between the two. It's a hard navigation for either program, but to then be thrown into both, it's difficult. But access and having advocates and other people who know the services being able to help and provide a service to make sure that there's no gaps in services is important. Thank you.
Thank you so much for that, Michelle Rousey. And now I'm so pleased that we have the Director of our Department of Healthcare Services, Michelle Bass, with us. Michelle, thank you for being here, and welcome any reflections that you have at this moment.
Thank you for the opportunity. I had to take a call from 2:30 to 3, so I didn't hear most of the conversation, just heard the last maybe 3, 4, 5 minutes. And so just want to acknowledge the comments and kind of the goal to engage further on CalAIM and how do we get more community-based providers to really be kind of our implementers of some of the community support. So look forward to future conversations. Just want to acknowledge I did hear some of the comments, but not the entire conversation. So I think definitely committed to engaging more on this.
Well, thank you so much, Director Bass, for being here. And we will definitely follow up with you to give you a summary of what we heard, and then can explore, how to continue this conversation. So now I want to turn it over to Director DeMorris, who will continue us on to the next phase of our agenda. Thank you all for a wonderful conversation, and thank you, Bree, for a tremendous report and discussion.
And then you got one of them in the right place.
Again, so thank you. That was a wonderful discussion, great comments. And I love the idea of a small CalAIM working group, because time is of the essence as that work moves forward quickly. We're now going to move to our next topic, building from the strength of our committee. Marty Emoto. Marty, thank you so much for stepping up and leading as you do so well, so often, and organizing members of this committee and others around the housing for all ages and stages topic, and really providing that backbone for our working group on housing. Marty and Patty, who is already well established in this space and our co-chair, Marty and Patty are now going to share with us the work that's been happening between meetings. Thank you both.
Thank you. I'll go first. And first of all, I want to thank the department for providing the resources for us to do the meetings of the subcommittee, because without that we couldn't have done it. And also to Patty and the other members of the subcommittee and providing the time and effort to do these meetings. We met several times since the full committee has met. And we did agree on a couple of things. One of them was that the priorities that we would work towards were going to be actionable, meaning these were steps that we can take that can actually move forward an issue or proposal. In the same way that we adopted that mindset for the master plan for aging, which I thought was remarkable. And I'm looking at you, Susan, and Sarah, and actually Claire, when we all worked together in the subcommittees, and we really focus on actionable items. And what developed from that, and I think was really proof that that's an important way to work, is that we came up with we all considered a master plan that actually was actionable. And a lot of the things that we see have happened now are things that are largely due because of that. And believe me, in all the work that I have done, and many of us for the last 20 years, we had not seen that before, to see it, that actually something can happen. And I think based on that, our subcommittee has taken that approach. And definitely one of the issues, and Patty will speak to it, was the issue of housing stabilization. And she will speak to that and provide an update on that. But the other action steps we took was making sure that we agreed that there was an intersection of equity, of the issues of transportation. And Michelle, you have always, and Debbie have raised that issue constantly, that there was an intersection of those issues of equity and transportation supports, and that you can't do one without the other. And the other issue, of course, is access, including language access that Sherry and Lisa, have advocated so strongly and always remind us of. Based on that, we also focused on some actionable steps. And one of them was to raise and ask the committee to have a presentation on CalAIM, focus on community supports, and also touching on the issue of housing, which this committee has done. And we also want to further engage with the managed care plans and with the Department of Healthcare Services and community organizations on the issue of community supports and housing. And maybe if Sarah, your idea or suggestion to form a work group on CalAIM, it will address that issue. The other was many of the subcommittee members identified the urgent need now to engage with local housing authorities and local housing programs, either run by the counties, and for all of us to work together and communicate with each other. That includes regional centers, community-based organizations that serve people with disabilities and older Californians, people with who are deaf, people with mental health issues, and to actually engage and move on that. And one idea was to see if our subcommittee can do a series of webinars, kind of based on, and looking at you, Sarah, on the Wednesday webinars that the Department of Aging has successfully done. And I sat in on a couple of those. Those are amazing, and they're not long, but we also are very conscious of not overtaxing the resources from the Department of Aging. And I'm looking at you, Susan. So we're going to be very careful on how we approach this, but we just think that if we do a webinar that actually moves and takes action on these things, we would invite the full committee to participate as well. And lastly, I think it's really important that we take the steps as an action step to identify those existing state laws that actually create barriers to housing and accessing housing. And we can talk more about that later. And I want to first of all turn it over to Patty, and then open it up to the subcommittee members to weigh in on any points that I didn't raise, or if you want to add to it. So Patty?
Thank you, Marty. And it's really been wonderful to have Marty lead this group. He has very collaborative and intersectional ways of looking at the need for housing for older adults and people with disabilities, and the ways in which we can advance community living. But very grounded in reality, very grounded in what can we get done. So I really appreciate that and the efforts of the group. Marty mentioned a couple of things that I want to touch on. I think the talk about equity, equity is really crucial and foundational to all of our work, but in housing, where we have so much of a history of discrimination and structural inequities that have persisted over time, I think it's just got to be core to how we approach older adult homelessness and housing instability. And the idea of community supports in housing, I was really pleased to hear this presentation today on CalAIM, but I think we really want to see the community supports that relate to housing lifted up in their importance and their and the outreach, that there are tenancy, location, and navigation services. There are tenancy sustaining services. There's a big menu of all of those Medicaid reimbursable items. And we want to see those front and center to the CalAIM efforts. And one of the things that we talked about that overlaps with the conversation we just had is that it's so important that the people who can benefit from this, people who are the plan participants, know about the scope of benefits, have a way to decide which ones meet their needs, and to have a way to ask for things and disagree with a denial of those services if they are denied. So I think some notice, some due process, and some ability to really have an informed and educated patient group, which, you know, if I look at all of us trying to understand these complex myriad 14 different supports, and I think, okay, how are we going to do that? How are we going to actualize that? And the piece that I keep thinking of is all of these community supports are based on having a home, and you can't do any of the other things without that home. So we need to keep returning to that. The only thing I wanted to mention in terms of actionable items is the subgroup did take a very positive, affirmative endorsement of a bill that is before the legislature right now in a budget request, which is AB 2547, jointly authored by Assembly members Nazarian and Wicks. And that bill would create a housing stabilization program that is targeted to people who are at imminent risk of homelessness or currently unhoused, who are older adults, age 50 and over, or people with adults with disabilities. And we think that it's really important to step up our game in the area of homeless prevention, because we're doing an okay job of getting people housed, but we can't keep up with the influx of new people becoming homeless for the first time, especially acutely low-income older adults age 50 and over who are becoming homeless for the very first time. So that bill, just to give you an update, has passed out favorably from Housing and Community Development and from Aging and Long-Term Care. It is now, it was heard in appropriations and is in suspense. And we have a budget request in. You may have heard an original number that was $1.4 billion. We have now revised that number downward to $750 million. And we really look forward to working with the Department of Aging and with all of the sister agencies that are involved in housing to stand up this program. But what makes it unique and really central to this committee's work is that it would create much more of a no wrong door for services, housing related services, where local area agencies on aging, housing authorities, ADRCs, community-based organizations could come together and submit a grant to administer these subsidies. And that means that it will be a much more, it'll be much more easy to do outreach and engagement with the aging and disabled communities. I think that's all I need to say. I see that there's a question from Lydia. We hear from our CBAS centers that housing instability is a major all hands on deck emergency, that staff need to spring into action to prevent escalating to a crisis leading to homelessness. Prevention is key. Nina asks, is the bill still moving this year? It is still alive and moving. Is Liz Fuller still on the call?
Hi, Patty.
Hi, do you want to give any update, Liz?
Well, it was through appropriations last week and moved to suspense. Obviously, with a price tag like this, of course, it's in suspense. I think that we're learning new things all along the way. I just sent Patty some amendments that we have that will take the bill down in price. And I think that we're looking at those and we certainly are hoping for the best. And if nothing else, that we're learning lessons this year that will help us in future years. But I think that one of the biggest lessons learned is that the real highlight of this bill and the reason that it's resonating with so many in the legislature is because these shallow subsidies and how many people it can help remain housed, which is so unique to this population. These are people who have housing, and really a small and very shallow subsidy can allow them to stay in the house that they're choosing to be in, that is in that community where they hope to reside. So I think that we're learning that that's really one touch point in this bill that's very helpful in moving it forward.
Thank you. And I didn't properly introduce Liz Fuller, who is the Chief Consultant for Aging and Long-Term Care Committee and has been a champion of this bill. And so we really thank her. Just a couple quick points. This is obviously aligned with the major goal of the Master Plan for Aging to end older adult homelessness. And it also it aligns with the Senate budget priority to create a stabilization for older adults and people with disabilities to prevent homelessness and rent instability. And of course, it is one of the two major items in the impact report that has been chosen as a priority for the next year of master plan implementation. And we really thank Susan and all of the CDA staff for their leadership on this as well.
Susan, this is Marty. I know that we're running short of time. I think we do have one, where we did have two. I think Aaron and Shella had questions, but I know that we have another item in this segment, and with the state perspectives on stakeholder input from Courtney. I don't know so I want to turn it back over to you, Susan, if you want to, how you want to handle this.
Great. Okay. Thank you, Marty.
But I'd rather have you be the bad guy. And thanks, Pat.
I would suggest, I did see Aaron and Shella's hands, so we will come back to you. Let's hear from Courtney Tracker with the who heads up local initiatives with the Interagency Council on Homelessness, in case Courtney has to leave us for her scheduled departure. Thank you, Courtney, for being here. After Courtney shares with us, we will take our break. We've been asking you to stay with us for 90 minutes now, and so we will take our break. And then Aaron and Shella will resume with you when we return. Welcome, Courtney.
All right, great. Thank you so much. I did have a PowerPoint I could put on the screen for you all if I'm able to take over sharing. Otherwise, I can just speak with you all.
You should be able to take over screen sharing, Courtney, but let us know if it gives you any trouble.
Oh, here we go. Thank you. Okay, great. Unfortunately, I won't be able to put it in presentation mode, but I will go ahead and get started with you all. Thank you for having me this afternoon. My name is Courtney Tracker, and I'm the Director of Local Initiatives with the California Interagency Council on Homelessness. And I'm here today to provide an overview of the California Interagency Council on Homelessness, or CAL-ICH, and the action plan for preventing and ending homelessness in California. And I think we'll touch on many of the discussion points that I heard shared in the comments before starting this presentation. The California Interagency Council on Homelessness was established in 2017 as the Homeless Coordinating and Financing Council to oversee the implementation of Housing First policies, guidelines, and regulations to reduce the prevalence and duration of homelessness in California. California is a housing first state, which means it's adopted statutory and regulatory language requiring programs receiving certain funding to utilize a housing first approach, which centers around providing or connecting individuals experiencing homelessness to permanent housing as quickly as possible. The mission of the council is to develop policies and identify resources, benefits, and services to prevent and work towards ending homelessness in California, as well as interagency coordination and policy development. As of January 1, the council was renamed the California Interagency Council on Homelessness and restructured to more accurately represent the council's purpose of being a unifying force in the state's response to the homelessness crisis and deepen coordination and collaboration across systems to work towards preventing and ending homelessness in California. The council is co-chaired by the Secretary of the Business, Consumer Services and Housing Agency and the Secretary of the Health and Human Services Agency, and is comprised of 20 representatives from several state entities and includes 5 recently added departments, such as the Department of Aging and the Department of Rehabilitation, to ensure that no area is left out of this critical work and further interagency collaboration and coordination. Cal-ICH also works with local systems of care, including California Continuums of Care, which are regional or local planning bodies that coordinate housing and services funding for families and individuals experiencing homelessness. As of the 2020 point in time count that was conducted on a single night in January, over 161,000 people were experiencing homelessness in California, with 3/4 of those individuals experiencing unsheltered homelessness. Additionally, the Homeless Data Integration System, launched by Cal-ICH last April to provide a comprehensive view of the state's homelessness service provision, tells us that over 240,000 people experiencing homelessness access services from the state's homelessness response system throughout 2020. Of the individuals experiencing homelessness that access services in 2020, 21% of those individuals served were ages 55 and over, and 42% reported having a disability. In March of last year, the council released the first action plan to prevent and end homelessness in California. And this action plan focuses on a vision for the council and state's work to prevent and end homelessness that features increased leadership from the state for identifying and supporting short-term and long-term solutions, purposeful action-oriented coordination and alignment across state agencies and programs, and stronger collaborative partnerships with public and private partners in communities. The plan covers the state's fiscal years 2021 through fiscal year 22-23 and will be updated ahead of fiscal year 22-23 to be inclusive of the new council member departments and make any modifications to the plan's objectives and identify more specific activities to be implemented during the fiscal year 22-23 to ensure that the action plan reflects the full scope of work of the council. In developing and implementing its first ever action plan, Cal-ICH is pursuing a vision for the council and the state's work to prevent and end homelessness that's motivated by a vision where homelessness is rare because it's prevented whenever possible, brief and ended quickly whenever it does occur through a focus on housing first approaches and housing outcomes, and a one-time experience ended successfully the first time so that no Californians experience homelessness repeatedly. The vision for this action plan is not simply making changes in how Cal-ICH and state agencies do their work, but it also seeks to orient the state's efforts towards driving purposeful, meaningful, and measurable progress towards preventing and ending homelessness in California. The action plan also lays out the principles we center all of our shared work on, and those principles are as follows: pursuing racial equity and justice. Homelessness in California reflects stark racial inequities. The racial makeup of people experiencing homelessness does not mirror the racial makeup of the general population in the state. California is committed to tackling racial disparities in homelessness through the implementation of this action plan. Secondly, creating solutions for the full diversity of people experiencing homelessness. Strategies, activities, and programs must be trauma-informed and tailored to address the specific needs of people with different experiences and identities to support progress for preventing and ending homelessness for all people and for all populations. Seeking and valuing the expertise of people with lived experiences of homelessness. Cal-ICH seeks to strengthen partnerships with people with lived expertise through the formation of a lived experience advisory board to inform the considerations and decisions of Cal-ICH and member departments. Aligning state activities with housing first approaches. The implementation of this plan will advance a strengthened focus on housing first approaches centered around providing or connecting individuals experiencing homelessness to permanent housing as quickly as possible and in the right level of services to support their success. Balancing crisis response and permanent housing solutions. While we recognize permanent housing is the only true solution to homelessness, the thousands of Californians experiencing homelessness right now are facing urgent and dangerous crises every single day. Cal-ICH and its member agencies will balance a focus on the immediate crisis needs of people experiencing homelessness through supportive and non-punitive approaches with efforts to create the necessary permanent housing options at the scale needed. And lastly, a shared responsibility, accountability, and efficiency. Cal-ICH will foster and rely upon increased coordination and shared responsibility and accountability across state departments and programs, and will work in close coordination with local communities in order to create the solutions Californians experiencing homelessness need and support the greatest impact of financial resources and programs. The execution of this action plan is also supported through the formation of 5 working groups that are charged with implementing specific activities. And those 5 working groups are listed for you on the slide. Within the action plan, specific departments are identified who are expected to be represented within those groups, and members from other departments and stakeholders with relevant expertise will also be recruited to serve on those various working groups. Each group will also be charged with addressing racial inequities and with tailoring solutions and strategies for different populations of people experiencing homelessness. The action plan was divided into 5 distinct but interrelated action areas. The first action area focuses on system strengthening, and this action area includes activities that are focused on pursuing racial equity in response to homelessness and housing instability, engaging in partnership with people with lived expertise, supporting interjurisdictional and regional planning, partnerships to strengthen outcomes related to education, employment, income, and assets, disaster preparedness and response, and communications and public awareness. Action area 2 focuses on unsheltered homelessness interventions, and this area includes activities focused on addressing health and safety needs and increasing access to state-supported services and programs for people who are experiencing unsheltered homelessness. Action area 3 focuses on sheltering, and this action area includes activities focused on expanding the supply of safe, housing placement-focused sheltering and interim housing models, and addressing health and services needs of people staying within such programs. Action area 4 focuses on permanent housing solutions. This action area includes activities focused on strengthening housing first approaches and expanding permanent housing opportunities through the development of strategies, short and long-term rental assistance, and other rehousing activities. And lastly, action area 5 focuses on homelessness prevention. This action area includes activities focused on reducing entries into homelessness as people exit and or receive services through state-funded programs and systems, as well as enhancing communities' capacity to provide targeted homelessness prevention and diversion services and assistance. The action areas are further defined into specific objectives and activities to accomplish each of these actions. Under these 5 action areas, there are 15 objectives and nearly 90 activities that 13 state departments have committed to accomplishing, including Objective 15, which identifies specific activities focused on identifying strategies to serve older adults and people with disabilities at risk of experiencing homelessness, including meeting the need for in-home supports and access to licensed adult and senior care facilities as an example. Each activity includes clear timeframes and performance measures to ensure accountability and work towards preventing and ending homelessness. In November, CalICH adopted the fiscal year 2021 Action Plan Implementation Progress Report, which provides data, highlights, and details about our collective progress on these activities. CalICH is currently working with all member departments and agencies to be inclusive of the new council member departments, as well as any updates to activities from departments already represented on the council. And this will help to ensure that the action plan reflects the full scope of work of our council. CalICH has been holding input discussions with council agencies and departments, external stakeholders, people with lived expertise, and virtual public input sessions. And a discussion with the full council and opportunity to provide public comment will be available at the May 31st CalICH council meeting. CalICH will then complete discussions with council agencies and departments and external stakeholders, confirm revised activities with all member agencies and departments, and the updated action plan will then be discussed and adopted at the September 1 council meeting. In closing, I would like to just share forward a few resources that may be beneficial to learn more about what was shared forward today. Included on the screen is a link to both the action plan as well as the implementation progress report released last November. And if you'd like to learn more about the work of the council and updates to the action plan, the next council meeting will be held on May 31st.
Oh, thank you very much, Courtney. And thank you especially for sharing these resources so that members of this committee and the public can link to them and learn more. We appreciate that. There was one question that came in the chat while you were speaking. It was, do you know what the percentage of older adults was in the point in time count in January?
Data is still coming in for the most recent point in time account that occurred this calendar year. So I don't have that specific data element at this point. Just you're welcome to go on our website though, and we have an interactive dashboard that will allow you to look up data from both 2020, actually it's earlier than that, but from the last two state calendar years as well.
Great. And Patty's on it in the chat. She's also sharing some data with the group as well. So Courtney, Patty, Marty, thank you for the housing report. We did advertise isn't the right word, but we did have on the agenda that there would be public comment at this time. I want to ask for public comment from anyone who cannot stay with us until the end of the meeting when we have public comment again. So if there's anybody who needs to drop off and wants to make a public comment, we would love to hear from you now. Otherwise, at the close of the meeting at 4:45, we will have public comment. And the instructions are here. Maria, do you want to announce the process for public comment? And
sure.
Then we will break.
That sounds great. Yeah, for those who need to drop off, if you can select the raise hand icon on your Zoom toolbar, we can unmute your line, or feel free to drop your questions and comments into the Q&A and we can read them out loud. I did see a hand shoot up and then it went down. So I don't know, Anna, if you have to drop off later, or if you can hold till the end, just a couple seconds, or any others who want to jump in. All right, seeing none, I think, Susan, we can probably go to break and look forward to public comment towards the end of today's meeting.
Oh, thank you, Maria. So what we'll do right now, it's 3:44. We will take a 10-minute break until 3:55, and then we will ask our transportation group to present from 3:55 until 4:15. We'll then hear from Corinne Buchanan. We will take public comment and get back on track. So Thank you, Maria, for keeping us on track. Everybody, please enjoy 10 minutes offline and off your computer. And Courtney, thank you again for joining us. All right, it looks like it's 3:55 now. We're going to return. If everyone would tune back in, please. Welcome back. And now we will be, this is the first group that spun off a work group, and we're so grateful for that. Eric and Debbie are now going to bring to us the preliminary work of the transportation work group. And we invite you to present from you have up until 4:15. So
Great.
Welcome Debbie Toth and Eric Harris.
Great. Thank you so much, Susan. Really appreciate your leadership. And Debbie Toth and I were part of a subcommittee focusing on transportation. We heard from members of the DACLAC that transportation is one of our top priorities, and we really wanted to do a deeper dive into some of the main issues that the disability and aging communities experience when it comes to transportation in California. I have spoken about my lived experience as a wheelchair user and the frustrations that I've experienced using different forms of transportation in California. And so I don't need to rehash any of those, but it is really a high priority issue for us within my working capacity at Disability Rights California, and also just throughout the disability community. But I'm gonna hand it off to Debbie, who has done amazing work in this space and is really one of the leaders in the state of California when it comes to transportation for people with disabilities and those who are aging.
Thank you, Eric. And thank you, Director DeMorris, for having us today. And I will do my best to be kind to the interpreter and be relatively slow compared to my normal self and still get through quite a lot. So as our friend Bill Pelter often reminds us, the second habit of the 7 Habits of Highly Effective People written by Stephen Covey is to begin with the end in mind. Our end is really quite simple. Imagine a world where everyone can get where they need to go when they need to get there. Sure, there's nuance, which our friend Rich will talk about, but the essence of what we seek is indeed that simple. So next slide. How did we get here? We've covered this in the past DACLAC meetings, but it's always good to have a little refresher. At our last meeting, John Cunningham walked us through 3 decades of studies that sat on shelves that covered the structure of a transit system that is in constant self-perpetuating search of the status quo. This means it's harder for us to change this broken system when it's designed to serve itself and not its riders. And here I'm speaking specifically about accessible transportation. Accessible transportation must be designed with the needs of the rider as the driver of the system. And when I say accessible transportation, thank you, David Mendel, for asking me to define this term, I am referring to a broad spectrum of things such as paratransit, volunteer driver programs, door-through-door services, nonprofit program rides, accessible fixed route stops and buses, rollable pathways to and from all places and spaces, wayfinding, and the list goes on. The idea is if it's relating from getting from point A to point B and it ensures everyone can do it, then it's considered accessible transportation. And we moved from the term senior and disabled transportation to accessible transportation because the traditional system only recognized paratransit. And as you can tell, the needs go far beyond paratransit. And this is a change in dialogue, which obviously must happen to change the system. Next slide. So after the MPA debacle, which actually turned out to be a turning point for us advocates, and for those of you who have been sleeping for the last 2 years, that was the event where the entire body of recommendations from the Master Plan for Aging Stakeholder Advisory Committee were discarded and replaced with some innocuous platitudes calling for reviewing this and creating MOUs and using existing funding streams, ... But I digress. So let me start again. After the MPA debacle, I was invited to come here by now Governor Newsom's senior advisor on aging, disability, and Alzheimer's, Kim McCoy-Wade, to tell DACLAC about what happened and what we need. And that prompted a whole bunch of feedback, which was amazing. So those who asked to be looped into transportation issues were then invited to put together a presentation. And we did. And you responded resoundingly, and Caltrans was 100% on board and made some really beautiful commitments to disability and aging equity to this group, which then prompted some conversations with Health and Human Services and the Department of Aging about the need for a transportation subcommittee. So our next move was to create one. But first we had to set up the rules of engagement, if you will. So for our work, we began a facilitated conversation to help us articulate our shared values, dreams, and fears. So next slide, I'm gonna pop forward and then I'll pop back again. But this is what this group of folks who had expressed a desire to do something about transportation came up with through facilitated work. Our agreed upon values are inclusion, equity, collaboration, action, and follow through. This replaces the concept of effectiveness, because what is that? Sustainability and candor. Candor being, we aren't here to save anybody's feelings. We're obviously not here to hurt anybody's feelings, but if something's broken, we are going to talk about that being broken. The dreams of the group are that the subcommittee drives the internal work of political staff and our legislators, that there is participation and there are champions driving the work at all state agencies, that there are tangible milestones that are created and reached. And because of this work, everyone is able to get where they need to go when they want. The fears of this group, a lack of integrity, really focused around conversations not leading to action, and status quo, where everything remains the same. So now we're going to flip to the previous slide. Thank you. So we had, after we developed that sheet, we then had our first full meeting, and we had 66 attendees at that meeting. We heard from 5 Caltrans leaders and learned about their commitment to our issues and a variety of programs, including the Equity Index, the infrastructure bill, their state bike and pedestrian plan, the grant guidelines, and transit accessibilities. And we were able to share what our priorities are with them, which happened to be a little bit different. This is really a truly monumental first step, though. It's the first time that we have had Caltrans take a deep dive into us, to come to us where we are, to learn from us, to allow that to inform their work. So where we really have room to work in concert with one another is in their equity platform, which frankly can benefit from some aging and disability education and inclusion. I will come back to that in just a moment, but to finish this slide, the work of this committee will focus on immediate, and this Caltrans work is immediate, short-term and mid to long-term goals in getting to that place we talked about at the beginning, which is that everyone can get where they need to go when they need to get there. The short, mid, and long-term goals are policy and funding that I'll cover on the last slide. Let's go 2 slides forward now. Here we can see that equity, again, is silent. This is the Caltrans, what their definition of equity is, and it's silent on aging and disability. And so here is really our great opportunity for education and infusion and inclusion. So I am not saying something bad about Caltrans. I am thrilled that they are here to learn from us and that we have this opportunity and that they're coming to our place and space to learn. And it's huge. Next slide. These are our big, I won't say hairy, audacious goals because they're really quite simple. These are the big asks though. Director DeMorris asked us at the last DACLAC meeting to come up with 2 to 3 asks. And I think it's Deputy Director, although I don't know if I got her title exactly right, Steenhausen asked the same of us Senior Rally Day. So here they are. It's 2 asks. Modernize the Consolidated Transportation Service Agency legislation and fund it. I mean, it's really, really simple. We've gone over what the Ctsa is. It includes all of the things we want to see happen implemented locally in very similar context as the aging and disability resource connections, same similar concept with transportation, consolidation, single point of entry, all that fun stuff, and ensuring all those services are there. So this group, this transportation subcommittee is focusing on education, content, inclusion in all Caltrans planning and program implementation. 2, crunching through updating that CTSA legislation. We will do that work. And 3, working on the one-time and ongoing funding streams to ensure consistent and guaranteed funding. It is important to note there must be additional funding and resources for rural communities. And please keep in mind that we're in our infancy, so we will be developing more concrete work as we move along, and we encourage you to participate. Next, let's hear from Rich, who can help us understand what the nuance is.
Can I have my first slide? No, not talking about CTSAs. Who's going to talk about that?
Oh,
John?
I'm sorry. Maybe John was supposed to go next. My apologies.
Okay.
Hello, folks.
John.
Sorry, John. I was just cutting you out of the whole thing. Love you.
No, I was busy deleting some notes so we can make time. Yeah, my name is John Cunningham. I'm a transportation planner in Contra Costa County that is in the East San Francisco Bay Area. For those that aren't familiar, and I'm going to talk to you about the Social Services Transportation Act, which was passed in 1979, and specifically about an organizational mechanism that you've probably heard us mention before, which is called the Consolidated Transportation Services Agency. I'll refer to it as CTSA for short. Why was this passed? It was passed because, frankly, accessible transportation services were, and to a large extent, currently are, a bit of a mess. More useful language is that we were spending a large amount of public funds for poor service and limited availability. A bit more detail on top of that. Duplication of services were actually mentioned as a concern in this meeting earlier by a different speaker on a different topic, but that is exactly what was occurring back in the 70s and 80s in this area. And it's still going on. The Federal Government Accountability Office, in fact, has done about a dozen studies on this topic. And that's one thing that they have documented. For example, you have large buses showing up to the same trip origin, each picking up a single passenger and then going to the same destination. And so what was the purpose of the CTSA mechanism? And that's this slide right here. I'm not going to read each bullet point to you. You can see it there, but it was to address the very issue that I just described through addressing duplication of services and inefficiency. It officially sanctioned coordination and encouraged consolidation of certain functions of the many different types of providers providing this type of transportation, nonprofits, public transportation, HUD, VA, that sort of thing. The last statement in the slide is actually a good summary. It's a flexible mechanism to deal with the problem of inefficient or duplicative transportation services. Next slide, please. So the act passed in 1979. Why are we here? To put it bluntly, the incentives to implement were too minimal to have a big effect. I'll direct you to the bullet points on the slide, which I'll pick out the big ones. So an incentive here is eligibility for certain Transportation Development Act funds, TDA funds. You'll note that I say non-exclusive eligibility. This is actually going to be a disincentive that I'll speak to here in a bit. And then there were exemptions from certain PUC and local requirements and fees. I'm not a CTSA expert. I did actually work for CTSA early in my career, and I recall that exemption from certain portions of the gas tax were part of being a CTSA. None of these are particularly compelling, and sure enough, there has not been widespread deployment of the CTSA mechanism throughout the state. The disincentives, however, are many. There is this simple lack of funding. This is rather unique in the transportation field. Virtually every other segment of the transportation system has funding programs and certain policies that support it. This is unique again. And then the eligibility for these certain TDA Act funds actually created competition with much more entrenched and numerous parties. So as we are probably all sensitive to, nobody likes when their financial pie, the slices get a bit thinner. So it created a disincentive to create these CTSA mechanisms. And then the authority to establish CTSAs is delegated to transportation agencies. The largest constituency for this type of service are really more their social service type constituents, health and human services agencies type of constituency. And frankly, that constituency is not a priority for a Department of Transportation or even public transit providers. They have many other obligations in their portfolio. We go to the next slide, please. So Debbie spoke earlier about the recommended modifications to the CTSA mechanism, which is in the Social Service Transportation Improvement Act. And some of the most obvious one here, as you've heard her say it, I've said before, is we need a dedicated funding source. You can't build bridges without funding. Bicycle and pedestrian improvements in the past 10 years, they've received new policies and new funding mechanisms. We're asking for equitable treatment for this population. And then I'll skip down to authorities. The authority to create a CTSA should be delegated to the counties rather than the transportation agencies. Counties have a much more diverse portfolio, which means they're going to be more responsive to the constituency that needs this service. They have obligations for public health. They receive Older Americans and Older Californians Act funding. It's a multi-purpose agency that is more in tune with the constituency that needs this type of service. And then you can see in bullets further below some details. We're getting into the weeds that I don't think I have time for given our constraints here. So I'll leave it at that. Happy to answer any questions afterwards. And we can, I guess Rich is next.
Okay, I want to get down to the basics a little bit here. We want to know, are ADA minimum requirements for transportation sufficient? Next slide, please. Everybody knows what the Americans with Disabilities Act is. The ADA was designed to prohibit discrimination based on disability. Pretty simple. It was intended to guarantee that people with disabilities have the same opportunities as everyone else to participate in mainstream American life. For transit, since then, the ADA requirement has been interpreted to require a complementary paratransit service. In case you don't know what that is, it provides for an origin to destination service that is available where fixed route is provided, but generally paratransit service is provided within a 3/4 mile on both sides of the fixed route, so it's limited. Note the emphasis on this is not on ensuring that needed rides are able to be provided. Instead of that, it prescribes a vehicle, a minibus kind of, to be located or available within these parameters of 3/4 mile. It is not a guarantee of a ride or a promise to get the rider where they need to go. So this is kind of the wrong approach in our view. There was a report and a study published in January of this year in Health and Disability Journal, where a number of organizations reviewed the capabilities and needs of persons with disabilities and whether those needs were being met by the transportation options that were available. And they found that they weren't, that ADA minimum requirements are generally perceived as not sufficient overall, and especially whether people live in cities or in rural areas. And what was missing is they said that there was often a lack of availability of services, destination, purpose, and travel restrictions. If you can just go to the doctor, but you can't go to the store, if you can't visit your aunt, but you can, those kinds of limitations were not good. The cost of rides was often prohibitive. Some riders, many riders, have physical and mental limitations that make the use of this vehicle that's provided for them not a real opportunity for them to get where they need to go when they need to go there. And there are often requirements for advanced planning. They have to wait. Travel time is long. There are a lot of things with the current availability of services that are not acceptable or satisfactory to riders. That was very well expressed in the report. Please, I have the link there. Oh, can you go to the next slide, please? Next slide, there we go. There it is. There's the link. If you go to that link, you can read the full report, and it's very edifying. Our committee has reached a consensus agreement, as you have heard, that everyone should be able to get where they need to go when they want to go and to be able to get there. The revised focus on alternative services that are successful in the provision of needed services for people with mobility challenges is our goal, instead of simple adherence to the minimum requirements of the ADA. Working from this viewpoint, we should expect the committee to consider and recommend ways that policy and funding can be adjusted to refocus on rider needs and capabilities, as well as opposed to transit needs and transit capabilities, and to make sure that transportation services for people with disabilities can be available when needed, effective in providing rides for required purposes and to needed destinations, not constrained by the kinds of things that they are now. You can't leave this city, you can't go there, you can't do this. There are a lot of things like that that impact the ability for people to use the transportation that is provided, that it's safe, that it's convenient, that it's low cost, and above all, that it is satisfactory to the riders who we would like to be able to provide the service for. Debbie?
Thank you. And finally, your superstar DACLAC committee member, Michelle, has a little plea.
Hello, everybody, DACLAC members and people of the public. I want to give you a challenge to come meet with us in our group. The Transportation Committee needs support from not only DACLAC, but more members of the community coming in, and so that we can bridge that gap of services and that we can get everybody on the same page and working together. So I challenge you to come meet with the next Transportation DACLAC meeting. Thank you.
Thanks, Michelle. And I think that we should probably say that we don't even have the next one on the calendar yet. We have to do a doodle poll to find out what the best date is for all of us to be able to set aside time to meet. So that should be, for those who have expressed interest, it will be coming to your way soon. There may be a smaller group of us that do that doodling, and then we will send it out to the larger group, but happy to do that. And we will take questions at the end when you are ready for them. Thank you.
Thank you. Well, Michelle, I accept your challenge. I'll be there. I've learned so much from this group, and I just really, from our own community, but also from the experts that you brought in, John and Rich, thank you so much. What a wonderful education. What a great presentation. Thank you for preparing the slides. So we've got this language in hand now. Outstanding work, outstanding work. Thank you. We're very grateful. And now I'd like to celebrate that till 5, but we're going to move to our next topic. My colleague Corinne Buchanan is joining us now. Corinne comes from the California Health and Human Services Agency, and she has been leading internally the work on Care Court, and she's going to update this group on where things stand today on May 11th, 2022. Corinne, welcome.
All right, thank you so much, Dr. DeMorris. Hi, folks. I'm Corinne Buchanan. I think I've presented for you maybe just once before, but by way of background, I'll share that I serve as our Deputy Secretary for Policy and Strategic Planning within the California Health and Human Services Agency. I've been working on issues related to providing housing and healthcare for individuals who are unhoused and individuals who have complex physical and behavioral health conditions for about the last 15 years in the direct service and at the county and state level. So that's a little bit about me. I want to say I really appreciate the opportunity to be here today to talk about Care Court. We have been doing quite a lot of stakeholder engagement related to Care Court. We've met with peer organizations, with housing and homelessness advocates, with racial equity advocates, disability rights groups, provider groups across the state. And I expect that this opportunity, like many others, is a chance not only for me to talk a little bit about Care Court, but to hear your feedback. And I expect it to be your honest feedback, and I'm ready for that. And I think that we make strong policy in California by listening to people who are directly impacted by these policies, and look forward to hearing from you today. When we get to that, we'll leave time, not just question and answers. You can give me your real feedback. I'm ready to hear it. So I will we're going to get into Care Court, I promise, but I wanted to just give a little bit of context to this systematic change that's happening in our behavioral health space before we jump in. So we're really committed across the administration to transforming our behavioral health care delivery system. And it's about creating generational change so that all Californians have access to high quality, culturally responsive, and easily accessible behavioral health care. We've made some critical investments in the last couple of years to build a new behavioral health capacity. And I'll talk about a couple of those examples in a moment. And then also importantly, to reduce fragmentation in the system. And especially what we mean by that is to create a more unified system that addresses both mental health and substance use disorder. And of course, this work is also about reducing stigma, where behavioral health care often was not considered a core component of our healthcare system. We're going to talk about parity in a moment too. Next slide, please. So in the recent past, I guess it was about in the last 6 months or so, the Department of Healthcare Services released a report called Assessing the Continuum of Care for Behavioral Health Services in California, Data, Stakeholder Perspectives, and Implications. And I thought I would just highlight a couple of the important findings from this report, which looked at the capacity challenges across our behavioral health continuum here in California. And the things that were lifted up as really important needs were comprehensive approach to crisis services, more community-based living options from housing and long-term residential for people living with serious mental illness or substance use disorders, a need for more treatment options for children and youth, both to serve people with complex care needs as well as to prevent behavioral health conditions. We also saw a need for both services and strategies to advance equity and address disparities. And a real need to address the housing, economic, and physical health issues, especially for individuals who are justice involved. So there's a link, hopefully we can get it to you. It's hyperlinked in this slide deck, but we've got a link to the report in case folks are interested. And when I stop talking, I'll put the link in the chat too. Next slide. So just wanted to highlight a couple of these investments in recent years. And the first, you've probably heard a lot about our CalAIM, our Medicaid reform, which modernizes, improves, and tries to simplify our behavioral health system, including payment reform opportunities within our behavioral health system in California, and the CalAIM Justice Package, which is aimed at serving people who are justice involved, especially connecting them to the care as they come out of carceral settings in California. You may have heard, we made a really big investment last year called the Children and Youth Behavioral Health Initiative, which is an effort to reimagine what our behavioral health system could look like for children and youth. We launched a program called the Behavioral Health Continuum Infrastructure Program and the Community Care Expansion Program, which are infusing capital dollars across up and down the state to create new behavioral health treatment settings, as well as settings that can serve seniors and adults with disabilities in a variety of housing settings, including assisted living settings and permanent supportive housing. We've launched a new peer support services benefit in Medi-Cal, which will launch soon. And the Department of Managed Healthcare has been involved in enforcement around health parity in particular. Next slide. We've established an Office of Suicide Prevention, doing a lot of work, and we're about to launch this, so we'll be excited to share more as it becomes available. But we're looking at a planning process around crisis care continuum, and in particular preparing for the launch of 988, which will be the mental health crisis line that launches in a matter of months. We are doing work around increasing access to medication-assisted treatment and piloting contingency management, which is a voluntary reward system, and evidence-based practice around serving people with substance use disorders. And then we've also done a lot of work with our, this one happens to be near and dear to my heart. I worked on this when I worked at the county in Los Angeles, but creating diversion and community-based restoration programs for individuals who are incompetent to stand trial, but who are facing either misdemeanor or felony charges. So how to create more community-based treatment options for that population. Next slide. And then we're going to get to care court soon, I promise, but the next one is just, we'll have to highlight how important the workforce is to be able to actually accomplish these goals. So we, in the governor's January budget, proposed $1.7 billion to focus on both within our agency here at CalHHS and within the Labor and Workforce Development Agency to create a more ethically and culturally inclusive health and human services workforce that includes our behavioral health workforce. We've got funding specifically around recruiting, training, and certifying community health workers, social worker investments, psychiatric residence program, and a multilingual health initiative. All right, let's move on. Okay, now we're here to Care Court. So Care Court, called the Community Assistance Empowerment and Recovery Court, is a new approach, and it is in a paradigm shift in how we serve people who have the most complex mental health conditions, with a goal of preserving self-determination and community living. The vision here is that Care Court is about diverting an upstream intervention to divert people from more restrictive conservatorships and in some cases incarceration. And Care Court is based on evidence that demonstrates that many people can stabilize, begin healing, and exit homelessness in less restrictive community-based settings. Care Court is about ensuring participant and system success. So Care Court is a civil process that brings together an individual suffering from a complex behavioral health condition, but it also is about creating accountability on ourselves at the state and at the county level for the delivery of behavioral health services that are holistic and meet the full needs of the individuals we're hoping to serve. Next slide. So Care Court, while it is a civil process, is quite different than mental health or LPS conservatorship in that it does not include custodial settings or long-term involuntary medications. Conservatorship law and in practice in California often uses as a frontline approach locked settings, and also often includes involuntary medication orders. Care Court does not do those things. It is a little different also in that it can be initiated by a petition to the court from a variety of individuals. It could include family members, clinicians, and others, and with what I would call quite a high bar in terms of evidence required to be able to move forward in the court process. As I mentioned before, local governments are also held accountable through the care plan. So local governments are actually court ordered to provide the services that are identified in a care plan, and we'll talk about what a care plan entails in just a moment. But if a county fails to comply with the court orders, they could be assessed penalties and even face a receivership. The Care Court model would also provide a supporter who's trained in supportive decision-making to help an individual who's served through the Care Court model to identify, to voice, and to center their care decisions in the creation of all of the care plan and the graduation plan, and would include, if desired, the creation of a psychiatric advance directive that could guide what care could look like in the case that an individual relapsed or their mental health was deteriorating. Next slide. Okay, and I probably should have started with this when I started talking, but I think some of you may be familiar with the Care Court model, but it's a proposal, and it's also that the governor introduced in March and is now a bill in the Senate, 1338. Should have mentioned the bill number when I started, but in case folks are following or you'd like to follow, That's the bill number. All right, so the next slide is just to describe for you who we're talking about in terms of, let me go back to the criteria, please. Thanks. And I want to say and be clear that the care court criteria is quite narrow intentionally. We're hoping to serve individuals who have schizophrenia spectrum and other psychotic disorders, and individuals whose judgment is so impaired by the symptoms of their mental illness that they lack the capacity to make, they lack medical decision-making capacity. So we're really talking about individuals who, because of their either lack of insight or judgment, are at risk to their own health and safety. Care court is not for I will say, many of the individuals we're hoping to serve may be individuals who are experiencing homelessness, because this, unfortunately, the status quo means that many people across California who have these conditions are experiencing homelessness or risk of homelessness, premature death, incarceration, conservatorship, and hospitalization, and that is what we are trying to avoid. So while this is not, it's not specifically for people experiencing homelessness, we know that many of the individuals who are in this population may be experiencing homelessness. And the goal here is really about serving people before they might ultimately enter the justice system, because many of these the folks in this population end up being criminalized for their behavioral health condition, which is what we are trying to avoid, or could end up in an LPS conservatorship. Next slide, please. So I'll just very briefly walk you through how the process works. As I mentioned, it starts with a petition, which could come from a delineated set of individuals who could petition to the court, including family members, clinicians, homeless outreach workers, and other named parties. The next step would be a clinical evaluation to determine if the individual meets the care court criteria. And the goal here also is to begin, the clinical evaluation would be conducted by the county behavioral health. And the goal here is also to begin to create the care plan. So next, the county would work with the individual supporter, the public defender as well, because all individuals who are referred to care court would be assigned a public defender to support their due process rights throughout the civil proceedings, to design a care plan that meets the needs of the individual. And the care plan includes 3 components. The first is access to behavioral health treatment that meets the needs of that individual. The second is stabilizing medication. So we know that for this population, access to medication makes a big difference in the ability to be able to live in the community in the least restrictive setting possible. And then third, a housing plan. And I'll talk about that a little bit more in a minute, because housing is extremely important to the care model. I'm sure that won't be a surprise to any of you how important that piece is. The second is the support. So the county behavioral health, after the care plan is created, and again with the role of the supporter who's involved in helping the individual to ensure that their wishes and desires are incorporated into the care plan. So after we finish the care plan and we move into the support, and it's as I've mentioned, a very important part of care court is the accountability on the county behavioral health to deliver those services. There would be periodic hearings where the court could hear about progress of the individual and the county and being able to make good on all aspects of the care plan, including the housing plan, and ensuring that the housing plan is responsive to the changing needs of the individual as they progress in their path to recovery. And then lastly, we end ultimately in success, where the individual is graduated from the program, and would include a graduation plan that would be conducted again by the county behavioral health, the individual, and their supporter, and may include a psychiatric advance directive. Next slide. I thought I would just take a moment and talk a little bit more about the supporter role, which as I have described is about helping the individual to understand, consider, and communicate their own decisions. So this is role of this supporter is going to be to help the individual understand the care court pathway alongside the public defender, to help the participant to understand, consider, and communicate their decisions, to give the participant tools to make self-directed choices to the greatest extent possible in the provision of their care and the provision of their housing, to help develop that psychiatric advance directive, And then again, in the creation of the graduation plan to make sure that the individual has a plan in place to support their ongoing connection to treatment as appropriate. And the role here is that the supporters would be trained in supportive decision-making and would represent a diversity of life experiences. In the proposal for Care Court, the supporter role would be funded and would be administered by the California Department of Aging, where they would create a network of supporters across the state. And when an individual entered the Care Court process, they could be assigned a supporter. The individual could also choose, if they prefer, to have a friend or a family member serve as a supporter instead of a state-funded supporter, or they may choose not to have a supporter at all. So certainly wanted to respect the choices of the individual and in having a supporter of their choice or no supporter at all. Next slide. We've got some questions about over the months about why Care Court doesn't include all behavioral health conditions, and we were very focused on diagnoses that had a functional impairment related to insight and judgment in particular that would put that individual at a health and safety risk. And also we know that these conditions are highly responsive to treatment, including stabilizing medication. As I started, certainly this is not to leave out other people in our behavioral health community, and is a big reason why we have a much larger effort related to our broader behavioral health redesign, including our children and youth efforts and our infrastructure efforts and workforce efforts. Again, we know that critical investments have to be made, as I described, in the capacity to reduce fragmentation, and especially to be able to serve people with the diagnoses that we've described in Care Court who may also have co-occurring substance use disorders. So being inclusive of a care plan that would meet the person's full needs across the behavioral spectrum. Next slide. Housing. This is the housing slide. This is the important one. Housing is really, really key to stability. I know I don't have to tell you all, really key to long-term stability, especially for individuals with complex behavioral health conditions. It's necessary for all of us, but we know that trying to adhere to any kind of treatment plan while living outdoors is extremely challenging. So all of the care plans will include a housing plan. We know that individuals in Care Court will have really diverse housing needs across a housing continuum with typologies ranging from clinically enhanced interim housing or bridge housing. Some folks may need licensed adult senior care, while others could move either immediately or after a period of time into supportive housing or other independent living settings, including affordable housing or housing with family and friends. It's important that the care plan be responsive also to the changing needs of the individual, especially as they stabilize and are on a path to recovery. The next is that I want to highlight another budget item in our 22-23 budget, which is $1.5 billion in funding for what we're referring to as the Behavioral Health Bridge Housing Program, which would fund clinically enhanced bridge housing settings that are well suited to serve Care Court participants. And in the Care Court bill, there's an effort to prioritize these resources for anyone who may be served through the Care Court process. And then, of course, we also, in addition to these sort of targeted dollars, this is happening in the context of the historic $12 billion investment that the administration and legislature have made to create new housing and homelessness response efforts, including, creating new programs for housing through Home Key, creating investments to end family homelessness, creating the community care expansion to serve adults and seniors and adults with disabilities. So in the context of, I think, what is a pretty exciting moment for us in California in terms of our very ramped up efforts to provide housing for all. So next slide. Okay, so I just put a couple of resources here. We're going to get to questions and discussion. This is where you all are happy to hear feedback as well as questions. I've added a link to the Care Court website that's on our Cal HHS website. Want to invite people also to check out our behavioral health task force within the California Health and Human Services Agency. And I also put on here our information about the Children and Youth Behavioral Health Initiative, which is also hosted on our Cal HHS website. For CalAIM information, you've got the latest there, and you have got my email as well. So we'll have some time for questions. If for some reason you don't get asked a question, you can always feel free to shoot me an email. So, all right, thanks so much. Now let's do. We can do however you do this.
Great, Corinne. Thank you very, very much. Thank you so much for presenting and the slides and the resources, and for sharing your email with the group. You've also developed a wonderful FAQ. So if anybody puts questions in the chat that are not answered, we will make sure that those reach Corinne, and that if they're not covered. So for the sake of time, I want to turn it over now to our co-chair, Eric Harris, with Disability Rights California. And Eric has been in conversation with members of this committee as well as others, and has prepared some remarks that he wanted to be sure that you hear. And then if time allows, we'll open it up to others. Eric.
Yeah, thank you so much, Susan. And thank you, Corinne, for your presentation. So I wanted to take a moment, and I know that some of you, and actually many of you, because I know that I've communicated with some, are aware that some folks within the mental health community, the peer community, the homelessness community, and various other civil rights organizations and groups have expressed some concerns with the proposal regarding care courts, the care courts proposal. And I just wanted to lay out some initial thoughts, and then we, of course, at Disability Rights California have on our website a lot of information on ideas that our experts have, especially a lot of our attorneys who work with members of the mental health community and unhoused people every day. And they have years of experience in the space and have offered some ideas. So just as a kind of initial point, Disability Rights California does agree that there is a crisis. There is a homeless and mental health crisis in terms of people who are on the streets, who do not have access to the services and supports and housing that they need and deserve. It's just a matter of determining the best way to go about making sure that those people are served the way that they need to be served, in the way that best fits their needs. And although this proposal focuses on people with specific types of mental health disabilities, such as individuals with certain types of psychosis, we express that it's very difficult to narrow down those specific types of disabilities like schizophrenia and others for those who are living on the streets. So just a few really quick points, and then I know we have to get to the questions. So one, I know that Corinne brought it up in her last slide, but housing is really the most important piece, making sure that people have access to housing in an accessible way for people with all different types of disabilities in the communities that they live and where their families are. We don't want situations where individuals have to move to other parts of the state where they might not have community, might not have their families. It's important that they have access to housing within the communities that they currently live. Another point that is really important is based on our experts' research and work, forced treatment is just not a reasonable option for people when you're trying to get the best outcomes. Voluntary treatment options are going to be the best option for people with all types of disabilities, especially people with mental health disabilities. And so that's one in particular that we think is really important, that there are as many voluntary options, as many community-based options for people with all different types of mental health disabilities as possible. And then a really, important point that we've been trying to look closely at is the impact that this proposal could have on people of color. Black people, Latinx people, Indigenous people are very often misdiagnosed, given the diagnoses of schizophrenia and other mental health disabilities. And it's really concerning to us, and we want to make sure that those people aren't put into a court system, even a civil court system, unnecessarily before they've done anything wrong, before they've committed any crimes. And so when courts are involved, and if a public defender is going to be involved, if the civil court's going to be involved, a brand new court system could potentially be involved, that could be really scary for a lot of people who have not done anything wrong. And those of us who have been involved in the legal system, court can even be intimidating for us, whether it's a civil court, a criminal court. All courts can be very intimidating if you don't fully understand why you're going to court and what the purpose is in terms of what the end goal is. And it's really difficult to know for sure how this is all going to play out. But these are just some of the concerns that Disability Rights California has. And I know that we're part of a pretty large coalition with over 50 organizations that have signed on that have expressed either concerns or even stronger issue with what we have seen so far when it comes to care courts. And ultimately, we believe at Disability Rights California that a full engagement process, I know Corinne mentioned it, that the governor and the administration has engaged with members of the civil rights community, disability community, peer community, and homeless community. But there are so many other people that have expressed to us and expressed to other folks that they have not been reached out to, they have not been brought to the table up to this point. And we really want to encourage moving forward, whether it's for this specific proposal, but even beyond just this proposal on these issues generally and on all disability issues, that it's critical that the disability community, a diverse cross-section of the disability community, especially people of color, are brought to the table for these discussions. So I just wanted to make sure that I made those points, and I appreciate you all for allowing me to have the time to say it today. Thank you, Susan.
All right. Corinne, I don't know if you wanted to respond to that, or we have a question or comment from Erin Carruthers.
I just want to thank you, Eric, for your comments. Appreciate it very much. And this certainly is not over yet, and I think we've got a lot more work to do in terms of continuing to listen with open ears and listen to feedback as this bill moves through its process. Yeah, certainly look forward to that.
All right, our last comment will be from Erin, and then we will go to public comment.
Thank you so much, Director DeMorris. And hi, Corinne. Erin Carruthers from the California State Council on Developmental Disabilities. We are an independent state entity with governor's appointees who exist to create positive, life-altering changes for people with developmental disabilities. And we're not an entity that signed on to the coalition that Eric talked about, but I really want to echo his comments and sign on to them in spirit. I also really want to acknowledge what you just said, Corinne, which is that the administration is listening with open ears. Because I think as we've watched through this process, we've seen the ideas, we've seen the proposal change in response to what's being heard. So I really want to acknowledge that and thank you. thank the administration for the attempt to tighten the eligibility, to really get some precision on who would be eligible under this. The concerns I hear about people with developmental disabilities are sometimes a little bit different. The term co-occurring in mental health is sometimes used for people with mental health conditions and substance abuse conditions. But originally the term was about people with developmental disabilities who also had mental health conditions. And it still is very true. It certainly is even more true after the pandemic. And really what happens in that experience for people with developmental disabilities is a system confusion. Who serves this person? If the person needs public assistance, if it's private insurance, go to your insurance for your mental health needs. But if it's public assistance, who serves? And oftentimes people are bounced between regional centers and county services as the two fight over who should be serving someone who is a regional center consumer. In reality, that just comes down to a fight over scarcity. And the concerns that I hear within developmental disabilities about CareCore is a continuation of making what's already currently scarce even more scarce by taking portions of those public resources and having the court have the ability to specifically tag it, claim it, direct someone people to it, direct the service delivery, the public service delivery system to prioritize who else is being served into this service first. What will happen then, and the fear and what I hear talk about in sort of the developmental disability kitchen tables, and you can often think of the developmental disability field as just some families around kitchen tables. And what I hear is that people think, or will be thinking, how do I fit myself under that criteria so I can get the scarcity of resources? And the concern is about just establishing a service delivery system that's based on acuity and a front door or a door to access that is through the court system, and people trying to shove themselves through that door, or the state building or expanding the door so that it's broader and broader and more inclusive. So think about it as in terms of how hospitals function now. If you need some urgent care, you actually have to go to the emergency room. And all of the hospital and medical resources are now realigned around this emergency room point of entry and point of access. That doesn't work too well. I haven't talked to too many people who think, yeah, this is a good, we did a good job landing on this structure. And the concern is that the mental health services will get realigned in the same way. Thank you so much for listening.
Thank you, Erin. Oh, go ahead.
Yeah, thank you, Erin. If like, maybe it might even make sense to talk a little bit more. What I took from your comments was like being thoughtful about access and being thoughtful about making sure that plans are holistic and not about passing the buck, but about more coordinated services instead of a hot potato approach to services for people with co-occurring mental health and DD. So thank you, appreciate it.
Yeah, and it is the structure of the service delivery system. So when we create this type of structure, then we create an access point that either people are going to try to force themselves into or broaden the doorway so that it ends up being the only way to get it is through court direction.
Thank you.
Great. Thank you, Corinne, again for being here and spending time to listen further on this topic and for our comments. We're going to open it up now for public comment. And I did have two announcements that I want to make beforehand, in addition to just thanking the experts around this virtual table, all of you subject matter experts in your personal lives, in your work lives, and the dedication and commitment that you all bring to this committee. Thank you, and the terrific work that's happening with housing and transportation between meetings. I wanted to share that our dear friend and colleague, Peter Mendoza, has been in an accident recently and he was hospitalized. And I just ask you all to please keep Peter in your thoughts as he gets to the other side of this. He's not with us today for that reason. So please please continue to think about Peter. And also, I believe that she's on today, but another dear friend and colleague, Christina Mills, will be leaving CFILC shortly to take on a new role. And we will miss Christina dearly on this committee and in our Aging and Disability Network. So Christina, thank you for your years of service and contributions to this committee, to the Master Plan for Aging, and all of the other tables and groups that you lead. We look for, I believe you're going to, is it Anthem? Is that right? If you want to open your mic, we'll continue to work with you in the bigger health system in your new role. And I know you'll be so successful there, and we'll educate your health plan on the needs of the disability community. Congratulations to you. So now we will open it to public comment, and Maria will take it from here. Thank you, Maria.
Thank you, Susan. So just a reminder about how to engage with public comment. If you see the raise hand icon on your toolbar, you can raise that and we will unmute your line to hear from you directly. You can also use the Q&A feature to submit your questions and comments, and we will read them out loud. And for those who are joining by phone, *9 will add you to the queue and we can open your line to hear from you. Okay. I do see that there was a couple of questions or comments submitted through the Q&A, and Robert, you've been replying to them, so I think others can see them too, but I want to highlight these. Patrick wanted to note that transportation is profoundly different in rural areas than in more populated areas, and how will issues related to transportation in very rural areas be studied and addressed moving forward? Thank you, Patrick, for that comment. No, you're not with us anymore, but thank you for engaging. Bill Pelter wanted to point out that to help seniors and people with disabilities stay in their homes, home modification is key for those who are low income. So thank you, Bill. Any other questions or comments from the public?
Maria,
And if not,
Shella and Debbie have questions or comments.
Perfect. Okay, I was just about to say we're going to hop over and see if any committee members want to share anything. So Debbie, I see that you had your hand up first, so go ahead.
So I'm a member of the public, even though I'm an honorary DACLAC member. Thank you to Director DeMorris. And I am on the transportation subcommittee, but I did want to answer the question about the rural transportation and just say that indeed we recognize, and I said in my comments, and I know that the person who was asking about that had to leave at 3:30, so didn't hear that, but that there has to be concerted and significant investments in rural accessible transportation, because there is so much need there. And most of the folks who live in rural communities don't live within 3/4 of a mile of a fixed route stop. So there isn't even paratransit for them. Much, I would say also there is no connectivity or Wi-Fi, and you can't call Uber, and you can't, so there are so many issues. So we recognize that. And the Ctsa structure will address that and will allow the needs of the rural communities to be met, but we have to fund it. So I think those are all really important things to say. I did want to make a comment earlier about the presentation related to CalAIM and note, and I don't know if Sherry replied to this or not, because I'm sorry, I had a distraction going on when Sherry was speaking, but the content that was given that said on the first scenario that there's a 60-day wait for CCT services, I wanted to clarify and say there is not. Currently, if you are in a skilled nursing facility or higher cost setting, it can be an acute care facility, hospital for 2 days. Second day on the Medi-Cal dollar, you are eligible for CCT services right now. We can transition people out. And Jeannie had noted in the chat that 60 days is too long to wait to be assessed. And I want to say, heck yes, it is, because by then people have lost their housing And so this is why advocates have worked with Senator Dodd to remove that wait period in the state of California. That is a California specific endeavor. And I think that we have a lot of work to still do on CalAIM. I think there's some still very medical bias to people who are actually more than just their diagnoses. So I just want to say that, and thank you so much for having this space and this meeting and everybody who contributes.
Thank you so much, Debbie. All right, and Shella.
Hi, good afternoon, everyone. My name is Shella Comine-Dumong, and I am on the Developmental Services Task Force and the parent of 2 adult children, one of whom is Simone, who has Down syndrome. I'm a housing advocate, and I'm also the executive director of Chance Housing. And I have a couple of items that I wanted to comment on, and I'll try and be as brief as possible. The first item is that the first time that I participated with this committee, I spoke of my daughter Simone, who has a Section 8 voucher and is in community-based housing. And she was being harassed by a male neighbor who had weapons and assault charges on his record. And we pulled every lever that I knew of. I called the landlord, I called the housing authority, I called disability rights. I called, we tried to file a claim under, to move her quickly under the Violence Against Women's Act. We filed police reports. We did all of this kind of stuff. And her health and safety was at risk. Nothing could happen soon enough to protect her housing. So we did eventually find her other housing. And at the time, this committee was considering whether the usefulness of developing a list or a resource that had the agencies, laws, regulations, legal resources, contact people, all of the different things that a family member, a parent, an agency would need to advocate and help their loved one who's experiencing harassment, and whether it be a senior or a person with a disability. Anyway, I was wondering if that ever got developed, because I wasn't able to find that. And I just wanted to sort of maybe put a bug back in the committee's ear to develop that resource and make it available for people. The second thing I wanted to speak on is relates to some of the housing issues that were discussed earlier, specifically how the state is looking at the whole person, including that housing is a priority in implementing the master plan for aging, how housing is a key part of the CalAIM's community services. And I just wanted to express that affordable housing for me, for my family, for the people that I work with who receive regional center services is always going to be an important priority. And in the course of the 23 years of this professional work, as well as starting to participate on these committees and subcommittees, I'm on the housing subcommittee as well, of this housing subcommittee of this committee. A couple of things have come to the forefront that I think would be useful and helpful, and would like to raise the awareness of. And the first one is that the Department of Developmental Services identify and create a high-level staff position for someone that deals with housing for our population. I don't know if there's anyone from the department on the call at this point. So I probably will try and get word or send an email out for that suggestion. And also that the department reconvene its housing work group of the Developmental Services Task Force so that that work group can do things like identify problems and solutions, work with this committee, this committee's housing subcommittee, and also to work with managed care plans who are implementing CalAIM and other kinds of community supports. The third item is for DDS to ensure that the implementation of the proposed new Division of Community Assistance and Resolutions and the creation of the statewide ombudsperson office includes steps on housing problems are handled, counted, tracked, resolved. And lastly, but very, very importantly, I want to underscore for the department the need for them to identify and consider rescinding or changing existing state laws that are inadvertent barriers to people remaining in affordable housing, accessing affordable housing, and receiving their services in the housing of their choice. And an example of this would be the department overcoming the state law that prevents people who live in a parental home or in the home of a conservator from receiving supported living services. And sort of like in this age of high housing costs and COVID protections and everything else, people should not be denied in-home care that they need, that they're eligible for, just because of where they're, sometimes forced to live. So that concludes my comments. I want to just say that this committee meeting was fantastic. I took extensive notes and I could have said a lot more, but I just want to thank you all, and thanks a lot. Bye-bye.
Thank you so much. With that, I just want to check, Susan, if you have any final comments. I think we're a little past time, so I think we're ready to close out, but I defer to you.
No, that's why I squeezed them in before. And just Shella, thank you so much for organizing, your thoughts. I heard that they're, you were very patient to wait to the end because you have several concerns that you wanted to raise. Thank you for that. And I just want to thank everybody for giving their time today, staying over a little bit later so we could hear public comment. And again, to thank the Kalina team and especially the incredible Amanda Lawrence, who you've all been working with in today's meeting, but especially in those work groups where all the great work is happening. So thank you all and have a good evening.